Hello.
Do not use Microsoft Excel without ChatGPT and AI because
Very good morning to all. Welcome to the National Conference Ephacon 24. We, the Department of Community Medicine, heartily welcome each one of you. So at the outset, I welcome our esteemed resource persons to take the oral to conduct the operational research workshop now. So I hand over the mic to them. We will have a formal inaugural session later. Thank you so much. Over to our resource persons.
Check. Check. Is it on now? No.
From near or far, we are thrilled to have us with you for what promises to be an inspiring and informative event. I'm Dr. Ashwini.
And I'm Dr. Nuzia, postgraduates of the Department of Community Medicine. We are honored to be here as host of you for this year's National Conference on Tuberculosis, Ephacon 2024. We have a fantastic lineup of sessions, workshops, and networking opportunities designed to provide you with the latest insights and tools. So let's make the most of this opportunity to learn, share, and connect. If you have any questions or need assistance, please don't hesitate to reach out to our conference staff.
Our first session is titled Operational Research: What, Why, and How. We are honored to have with us today a distinguished speaker who brings with him a warm wealth of knowledge and experience. Please join me in welcoming our first speaker, Dr. Akshaya KM, NTP STF's Chair, Karnataka.
Check. Am I audible? Good morning, everyone. At the outset, I would like to thank the organizers for having faith in us and inviting us for this particular workshop. So I would like to also welcome and introduce my fellow colleague, Dr. Kedar, who is from GMERS Medical College, Baroda. So we were co-participants in one of the OR courses way back in 2016-17, and we tend to carry some of these particular memories forward, as well as we would like to share our experiences, what worked for us over the last few years in this particular domain of operational research. So let's start the session. So just ground rules. It's always better that you can park your questions based on the slide numbers, whichever I would be putting, so that we can have these particular questions at the end of the presentation, because we have a very tight schedule of this particular workshop. So keeping that thing in mind, we would like to take up the questions after each of the session. You can just write down those and then we can have a discussion. Because these OR courses go for quite long, and we have tried to make a abridged version over here at least we require 3 to 4 days to just sensitize and teach some of these particular concepts of protocol writing in operational research, so which we are trying to fit in within probably 4 hours, which is quite a task. So yes, operational research, why, what, and how. So just introduction to what is operational research, why we should be conducting it, and how we can go about conducting, or what are the facilitators, or probably the you can say supporting factors towards conducting operational research, especially in the developing countries. So we'll be looking at some terminologies in operational research. We will be looking at some of the research question themes, and then why do we want to do operational research? Probably we want to improve the program outcomes, we want to assess the feasibility of some new interventions, and probably at the end of all these we want to influence some policies and bring about a change. And how this particular OR is relevant when it comes to programs, when it comes to policies, when it comes to partnerships, and developing a critical mass or building a critical mass, and then evaluate the success of research. You can note down the points, however the presentations will be shared. It will be shared with the organizers, and you can get it from them. And these are all presentations which have evolved over the last so many OR courses which have been conducted by the union, the support from WHO, TDR. So all these organizations have taken, people within these organizations have taken a lot of pains to prepare these particular presentations. We have added some things here and there, probably some of the things we have edited. So the whole credit of all the presentations will go to all these organizations who have evolved the process of structured operational research training initiative over the last probably 10 to 15 years. So what is operational research? Lancet defines that as it's a search for knowledge or interventions, strategies or tools that can enhance the quality or coverage of health systems and services. So there are some keywords which have been highlighted over here. So you need to search for some knowledge or interventions, strategies or tools. So final, what we are looking at improvement of the quality or coverage of health systems and services. So the Global Fund has a definition which probably is much more holistic, or probably involves more number of terminologies. So you can see that yes, knowledge is there. So what does this knowledge constitute? It can be evidence, findings, information, which can improve program implementation. So just see what all can come under program implementation. So please see these words: effectiveness, efficiency. I'm not talking about efficacy. Please remember, it is effectiveness and efficiency, quality, access, scale up, or generalizability and sustainability of the program or interventions, regardless of the type of research. One rider over here, the type of research, I'll tell you what are the study designs which can be applied in operational research. Yes, most of the study designs do fall under the category, except for some exclusions. We'll be looking at that in the next few slides. Always this is probably interchangeably used with implementation research or health systems research. So if you see, operational research is probably at a smaller scale or level, where you are using these findings in the local context, or the findings can be applied in the local programmatic context. Probably implementation research is used at a bit higher level by the program managers or health managers, and then when it comes to health system research, the findings are used to build policies. So yes, all these three terms are used interchangeably. The processes involved in these three, you can say the researchers are the same. So this is what actually the difference is. I don't say it as a difference, probably these three operate at various level of health systems, and you can see the beneficiaries who are actually there in these particular three types of researchers: healthcare providers, program managers, or health systems managers, or policy managers. So there is a subtle difference between the three when it comes to usage of the you can say knowledge which is coming out of these particular operational researchers. So yes, if there is a question asked on operational research, don't, or if it is health systems research, the principles of you can say research remains the same in all these three particular components whichever are being discussed. So this is especially for the postgraduates, and probably this particular diagram will be very helpful. People say community medicine cannot be represented in terms of diagrams. It is to be, you need to be more verbose. No, you can use such small things to be as precise as possible, and probably this gives a better understanding to the examiner or to the assessors that you know this particular topic. So I think that's clear. So OR probably is smaller than IR, smaller than HSR. Okay, this is the spectrum. And healthcare providers can be program managers, and program managers can be policy makers. So that's also thing which is there. So there is a subtle difference, usage of results as well as the end users, or what transforms following this particular set of researchers, whether it is OR, IR, or HSR. So the historical roots of operational research actually come from the military setting, right from the World War I, World War II, where the number of artilleries fired from a particular machine gun was to be reduced in order to bring down a plane. So there were different methods which were used to bring down the number of artilleries which are used to bring to make a plane fall. So it has its roots right from the World War I or II. Probably health systems have utilized these particular methods of efficiently using the artillery rounds to bring down a plane. Okay, this operational researches has been used in other fields also. Probably the penny post which evolved in England, where there was common postage you can say prices for a certain set of distances. And in theme parks, if you see the queuing system or the lines, how they are managed, Walt Disney started this, how to manage, efficiently managing the crew lines in the airplanes. So this is also one of the ways how operational research is being used, how efficiently they can use within the existing system and the set of resources. So those are historical roots as far as the operational research is concerned. So coming to the core, what is operational research and how the research questions are actually focused in this particular set of research. So there are some guiding principles in setting operational research agendas. First, we need to define the objectives. Obviously, it should be program objectives or health system objectives, understanding what interventions or activities are actually implemented to achieve these particular objectives. Then, identifying constraints in meeting the objectives. So that is what we are actually interested. So if a program has a definite set of objectives, so for example, TB program, if TB has to be eliminated by 2025, probably there are a set of objectives which need to be met in order to achieve this particular goal of ending TB by 2025, and probably there are good number of constraints which are there to achieve these individual objectives. Clear? So we need to identify what can be those particular constraints, and our research questions should be focusing upon these particular constraints, because we always say operational research should happen in the existing program and within the programmatic setting. So we need to identify the constraints. Second, we need to focus our research questions on how to address these particular constraints. Are you clear? So there are three main themes how research questions can actually be framed. So one is research question can be framed based on lack of knowledge, based on lack of a tool or an intervention to achieve a particular objective. Then if there is a tool or intervention which is already existing, probably if that tool is not used efficiently, then inefficient use of that particular tool or an intervention. So research questions can be framed or based on three themes: lack of knowledge, lack of a tool, or inefficient use of a tool or an intervention. We'll give examples to each of one example each to each of these particular themes so that it will be clear. Okay, let's look at this particular theme of lack of knowledge. All of us want that any chronic disease, for that matter, whether it is tuberculosis, whether it is asthma, whether it is diabetes mellitus or hypertension, probably we want to ensure that there needs to be a good compliance towards treatment. Agreed? So probably we would like to set a target of 90%, 95%, depending upon which disease we are treating, or even leprosy for that matter. So if we want to have such a question in our mind that what are the issues when it comes to probably not achieving this 95% target what we have set. So there is a lack of knowledge. Agreed? So for example, if a person is on treatment for tuberculosis, and if we say that this particular person has to complete this particular treatment whichever is being assigned to him, whether it is drug sensitive or drug resistant, within a particular period of time, and if the person is not achieving that within that particular period of time, then we are in search of knowledge, probably why this particular set of population or person or group of people are not achieving this particular 95% target. Clear? So probably that's what is our objective in a program. I'm just giving you a hypothetical example. So here, so achieve 90% treatment completion or excellent retention of on therapy. So 90% treatment completion, I am telling 90% of our patients need to complete the treatment, and retention of therapy probably in individuals. So in ART probably they need to adhere to the particular treatment for 95% of the days whatever they are being given. In asthma, smoking cessation tool, all these particular things, wherever retention is required, we are looking at probably what are the issues when it comes to we can say gaps in retention. Okay. So our constraint what we have identified is there are high losses to follow up in any of these particular therapies. So 30% of the patients are lost to follow up because of one or the other reason. So then we see only 70% of the patients who are put on treatment do complete the treatment within the stipulated time. So research questions can be like, why are people actually lost? Whether is there something related to payment issues, whether is there something related to some other addictions, whether there is related side effects, whether are there any transportation costs involved for the patients to reach the clinic and access the medicines, whether there have been deaths which have been not reported to the program. Probably all these might contribute to the question why people are lost to follow up, or they have not completed the treatment. So in such a scenario, this is one of the research questions. So answer to this particular question and finding solutions of how to go about decreasing the losses from therapy will be our focus area when it comes to addressing this particular research question of why are people lost. Is everyone clear? Okay, so this is one example which I am giving as far as the lack of knowledge theme is concerned. So next one, we are looking at lack of intervention. So one is lack of knowledge, second is lack of intervention, third is if there is an intervention, then whether that particular intervention is actually working or no. So this is actually apt when it comes to lack of intervention or probably a tool. So we all know that there is something called as triaging of patients with tuberculosis based on severity, and probably this triaging has to happen at the primary health center level at the time of diagnosis. There are some criteria which are being used probably by the medical officer or CHOs or other paramedical staff. So we need to see the severity at diagnosis, which are, there are some fixed criteria like body mass index, like respiratory rate, which and SpO2, which will tell about respiratory insufficiency if it is there or not, and patient is able to get up the functional status of the patient. So probably there are 3 or 4 indicators which need to be looked at the time of diagnosis to see whether this particular patient is severely ill or not when it comes to tuberculosis. So there was a lack of triage tool actually. So now there has been this triage tool introduced into the program, and we want to actually see how feasible is this particular tool to be implemented by paramedical workers based on whatever criteria I have told: severe undernutrition, respiratory insufficiency and performance status. So this can become a research question. Because there was a lack of tool, some lack of tool or some tool or intervention has been provided in the program, it has become a policy, and we would like to see whether this particular tool is used efficiently, one. If not, probably what are the issues or concerns surrounding this particular inefficient use of a tool. I hope this is clear, lack of a tool for diagnosis or treatment. Yeah, this is a very straightforward example. We all know that sputum microscopy, quality sputum microscopy is still a cornerstone, along with probably, yes, now NAT has come into the picture, but we still rely upon microscopy for our microscopically confirmed tuberculosis cases. And initially when this was a tool which was used, there were 3 samples which had to be given by the patient. So however, once this particular you can say the whole process of getting 3 samples was turning out to be very difficult. So there were ORs which were taken up to see what was, how 2 samples would be actually better or probably equal to that of 3 samples when it comes to diagnosis of tuberculosis. So 3 samples per patient are demanding for laboratory techniques over here, but probably we would like to say that this particular tool should be used or can be used more efficiently. So if you are seeing that efficiency of diagnosis is almost the same in 2 versus 3 smears, then why do you want to go for 3 sputum samples, increase around which the research questions can be actually focused upon? One is lack of knowledge, second is lack of tool or an intervention, third one is inefficient use of a tool or an intervention. Yes. What are the different study designs actually which can qualify under the operational researchers? We are looking at effectiveness or efficiency, and it should be happening in the programmatic context. So we are not looking at the efficacy, which is usually looked by RCTs. So RCTs are out of this particular domain of ORs. So never ever say that randomized control trials can be under operational researchers. No, the bottom line is very important. Research is done to enhance the quality or coverage of health systems and services, and they should be conducted within the routine existing system of the program. For that matter, any program you can take. Clear? So that is one thing. Basic science research doesn't qualify to be called as operational researchers. If they are trials, then they should be pragmatic trials or quasi-experimental studies happening in the programmatic context. Otherwise, they cannot be called as operational researchers. So your cross-sectional studies, cohort case control, community-based pragmatic modeling studies, yes, pure qualitative studies also can be brought under this particular domain of OR, and cost effectiveness and cost benefit analysis. Yes, mixed method studies are also there, so they also qualify under this particular domain of operational research. So probably the quantitative component should have one of these particular study designs in the mixed methods. Yeah, this is what I already told. We don't put basic science research, fundamental research or product development under operational researchers, and wherever efficacy is the endpoint, where it is being done under controlled settings, we don't qualify, we don't put that particular component under OR. I don't say that we need to exclude RCTs from you can say the research in medicine. Yes, they form a continuum. However, if RCTs are done in controlled settings, whether these particular drugs or whether these particular interventions do work in the real world is what we are looking at. So RCTs generally generate the knowledge in the trial settings, and then we would like to test them in the real world conditions, and probably yes, patients and communities would be benefited in the run. So for any implementation success, an important slide, if you see that implementation success is equal to efficiency of an intervention minus factors that affect the implementation. So efficacy of the intervention is looked at actually by the RCTs, and the factors that affect implementation is looked at by the ORs or IR. So efficacy in ideal conditions, trial conditions, minus what are the factors which actually affect when these particular trial conditions come onto the field is the implementation success of an intervention or a tool. Are you clear? Okay. So key elements over here, research questions are generated by identifying constraints or challenges. The answers to these questions should have direct practical relevance to solving these problems and improving healthcare delivery. We have looked at what is operational research. Now coming to why. Why is operational research relevant? Yes, the main important thing what we are looking at is that we need to look at improving program outcomes. So that's very important. The first thing why it is relevant. Yes, we need to assess the feasibility of certain interventions or tools in the specific settings, in the field settings, in the programmatic settings. And finally, if these two actually happen, and then if there are large number of evidences coming in support of a particular intervention or a tool, then we want to advocate for policy change. So this is what we are actually looking at the end of any operational research. So the policy can be at various levels, probably at the level of your district or sub-district. There can be a small policy which can be made depending upon the local conditions which are affecting a particular disease, which may not be there in any other part of India. Okay, so yes, operational researchers are needed to support, to advocate for policy change. So let us look at some examples when it comes to these three particular points which I have told why operational research is important. Yeah, it's an example from Malawi. Malawi is an African country where there was a very high prevalence of HIV in early 2000. Okay, the title of the study says that voluntary counseling, HIV testing and adjunctive cotrimoxazole reduces mortality in TB patients in Malawi, in Thylo, Malawi, published in AIDS 2003. So Malawi didn't have this voluntary counseling and HIV testing. So through an operational research, when this particular thing was introduced in Malawi, and when this particular intervention, when it was introduced following giving adjunctive cotrimoxazole to patients with HIV and TB, let us see what happens. So once HIV testing was introduced in amongst these particular patients, this is among TB patients I am telling. So you can see over the years from 2003 to 2010, the number of people who were actually tested kept on increasing. So if you are expecting this particular thing to happen, then obviously there are some results associated with that. We will see in the next slide. But the people who were turning out to be HIV positive almost remained the same. We were getting lot of denominators, okay, and lot of numerators in the form of testing. And CPT, which was being introduced in 2003, CPT was continued to all the patients, and you can see that there is a rise of CPT coverage as the years progressed. Similarly, ART also increased. What happened following this particular OR? So since these patients were HIV TB patients, CPT was given, treatment success rates kept on increasing over the period, and one of the other indicators which is used to say that it is successful outcomes, death kept on reducing. So don't you think that this OR has made a big difference when it comes to management of TB HIV? Okay, so this was a small OR which was published, following which there was countrywide expansion of HIV testing and cotrimoxazole given to all the TB patients, HIV TB patients. So the program outcome was improved following a OR or a small research which was published in 2003, and the effect could be seen over the next 8 to 10 years. Assessing the feasibility in conflict settings, there is something called as a SPEAR guidelines. SPEAR guidelines are being used to actually manage communicable and non-communicable diseases in the conflict setting. So earlier SPEAR guidelines said that in conflict settings we cannot offer antiretroviral therapy to the people who are migrating or displaced populations. Okay, so this was a OR which was taken up to assess the feasibility of HIV treatment in a conflict setting, again an African study. So this particular OR offered us knowledge on offering HIV AIDS care and ART in conflict, chronic conflict settings. Yes, obviously it led to the changing of the SPEAR guidelines, and SPEAR guidelines said that okay, we will start giving HIV care and treatment for the patients who are there in the conflict setting. So yes, this has led to this particular change, and the OR was focusing about whether is it feasible for us to introduce this particular intervention in a conflict setting. Yeah, coming to policy change, this is an example from, so that's what is being indicated from the literature. And then, yes, if you have to use this particular component of screening for diabetes among patients, yes, you need some evidence. You cannot do this based on a case series or a small study. So, in 2013, so all the TB patients across, it was a were being given a fasting blood glucose, and out of these, this might go still higher. We may have 20-25% of the patients with diabetes or with tuberculosis having diabetes mellitus. So, to ensure that there is an efficient cross linkage, the first point is that you need to screen for a particular disease. So, number with known newly diagnosed diabetes mellitus referred to diabetes mellitus care. 95% of these were referred for diabetes mellitus care, and this was a countrywide study which led to the policy change. And when it was being discussed in the forums with the TB NCD programs, you can see that the policy has come out before the findings were published in a paper. That is the power of OR. Okay. So, if you have right people on the board to communicate your findings, then it can go for a policy change. TMIH published this in 2013 May, but in September 2012 RNTCP was told that you need to screen all the patients with all the patients who are patients with tuberculosis for diabetes mellitus. Clear? So, this is a classical example which has led to a policy change in the Indian context. So, OR questions and outcomes can be looking at various themes under implementation, under services, under clients. So, probably another reference which tells that what are the different themes under which it can be looking. This is actually a more comprehensive or a broader list than what I have told earlier. Yeah, it would be given, you can take this, but anything and everything will focus upon those three particular themes which I had already discussed earlier. So, coming to the last part of it, operational research, how, or probably what are the facilitators or enabling factors for operational researchers. One is a direct program relevance. If you talk to the program managers or district program officials, they, especially I am telling for the people who are coming from academia, because we don't know many a times what are actually the problems in the field. But your health workers, your medical officers, your program officers will tell, okay, these are the concerns, really what I am having from the field. Those should give you sparks for getting OR questions. Okay? So, anything which has got direct relevance in the field, in the program, will be one of the research priorities for operational research. So, that is one of the obviously the biggest facilitating factor or the motivation for operational research. Next, partnerships. It is always a tendency of many of the funders or international agencies that the most of the research is dumped on academia, and they expect you to do research, bring out the findings and give it to them. But what happens at the end of the day, probably these are the people who actually support the implementation of your findings. If you are not taking DTO on your board right from the initiation of your research, he tells, I don't know what is research. Okay, because they are actually busy with, discussed earlier, how it led to a policy change. And one of the most famous call for proposals has come from call for proposals has come from one of the former OR fellows who was there with the union working with National Institute of Epidemiology. If you are interested, call for proposals is open till 17th of this particular month. Please apply. If you have any serious research questions and you need to give a commitment of 2 years from your side to take up the research, and out of this, at least the details of this, you have to submit your data sets to the mentors, and that is how you will be invited to attend the course. The most important facilitating factor is that we need to retain this particular critical mass which is being actually trained. Yeah, it's again related to brain drain. People get trained in OR, people I do PhDs taking these particular OR topics. However, if they are not retained in the developing countries, then there is no one to take this particular OR forward. Role of NGOs, very important, because most of these particular interventions, this is an example of how this is an example of how there was a policy change at the country level. So important, and those can be actually the facilitator to see to it that we continue the particular trend or the process of OR in future. So this is what I have already told you. What is operational research, why we need to do operational research, and how, what can be the facilitators with respect to operational research, especially in the developing countries. Okay, a very familiar picture with you people sitting over here. Our health systems are huge. Okay, they are overburdened, and at any point they can sink, especially when we have lot of captains and when we have lot of sailors who don't have a direction. Okay, all of us want to be captain in the health system, but nobody wants to be a sailor. One thing. Second thing is, all of us wants to be a team leader. Nobody wants to be a part of the team. Okay, in such a scenario, you can't expect that you can do OR. Clear? So we need this particular thing in OR. If you should ensure that OR takes up, and then you justify whatever research question you have taken, it should lead a logical end, then you need a captain. Okay, probably you are, or probably your mentor can be, and you need some people along with you to take OR to a logical end. Okay, so that's it from my side in as far as this presentation is concerned. Hope I have clear in communicating what is OR, how we need to do OR, and why we need to do OR. Okay, yeah, it's open for question answer session. Yeah, Dr. Kedar also will be joining me. The question answer session would be taken by both of us, because I am not saying that I am an expert, I am a learner. So if there are some things which we are not able to answer, we will get back to you. Yes, any questions? Systematic reviews. Not really. Yeah, you can actually do it. I am not telling that you cannot do, but yes, it should if it is actually influencing the policy change, if it is influencing the programmatic change, you can do it, because we have already put up cost benefit, cost analysis studies. It can be done. But yeah, systematic review with meta-analysis gives you you can say a better evidence than systematic reviews alone, but you have to see to it that whether these particular trials are community-based pragmatic trials, or whether they are in the ideal settings. If they are in the ideal settings, they don't qualify to be called as ORs. But if you have trials which are coming up from the field where they have been done in the programmatic settings, I am telling quasi-experimental, pragmatic, so then yes, you can do it. Otherwise, just systematic review and meta-analysis of trials done in you can say ideal settings, where they are in controlled settings, don't qualify. So again, you have to take the same definition when you are evaluating systematic review and meta-analysis. Anything else to add?
Sir, nice presentation.
Thank you, sir.
One thing,
Yeah.
I don't know whether it is directly related, but a couple of months back there was a news that we don't have TB medicines available. It was there was a lot of crunch of the TB medicines. So all these systems means we do a lot of OR and lot of analysis. But if we don't have the medicines available, then how we can lead to this elimination or eradication thing?
Yeah.
Any thought?
Let us keep the discussion only to OR.
Okay.
Okay. Availability and non-availability of TB medicines, probably it's a socio-political issue. So I don't want to comment on that, but yes, if you are looking at what are really the concerns with respect to non-availability, that becomes a OR.
Okay. Yes.
Yeah, but I don't want to pitch in and say what are the issues with respect to this, even though I know most of them. So
Okay, sir. Thank you. Thank you.
yes, we can actually take up that particular issue. See, yes, I'll tell you one more thing how this can be approached. You look at states. Okay, probably there are states where there is a good availability. Probably there are states where there is a not so good availability. Okay, factors which are influencing both can become a OR. Okay, if there are supply chain management issues, if there are issues with local procurement, there are local socio-political reasons, yes, everything, each of these can become an OR question. Okay, I have given you a lot of clues, but I am but I am not giving you the answer. I will not. Anything else, Kedar? Yeah. Yes, you can actually look at those particular things. Take the DTO, take the STO on board. Okay, and if they are a part of this, you have every you can say confidence, a right to publish those. Okay, just giving you one more example with respect to this. When we did ART, infection control in DRTB centers 2016-17, I did it in state of Karnataka. Okay, my STO was the senior author in this. Okay, so it says that he watches these findings. So because he is the person who has to actually set right those particular things if there are issues when it comes to airborne infection control. Because the funds have to flow from his side to the DRTB center. Whatever it is, whether it is a one-time grant or whether it is a recurring fund every year which has to go, it is he who has to budget. And if we are fine with reporting whatever findings are there, okay, then yes, then definitely he is also he is watching to the program saying that, okay, I put a stamp saying that these are the issues. We don't say that those issues might be solved overnight, but yes, the administrators, the policy makers are aware because something is in the public domain. Are aware from their side is different, but once it is put in a public domain, then they become more aware. There are more stressors on them to act either in one or the other way.
That sort of answers my question, sir. So in continuation to the doctor before and after me who asked, right now three of us are from WHO.
Yeah,
and
nice
we
to
are
have you,
into
ma'am.
Thank you, sir. We are into applied epidemiology program, and one of our activities is surveillance system evaluation, any program in India. So I think that also we can call it as an operational research.
Yes.
Yes. So personally, I'm evaluating the surveillance system of viral hepatitis in Mizoram. There also, it is sort of the same issue. we found out that the more we test, the more positive cases we find, but the what next part, the treatment, the free treatment part is a constraint on the government side. So I just wanted to share that.
Thank you, ma'am. That's a new thing for us, because we are, India is a very diverse country. What follows in the rest of India may not actually follow in the Northeast. Okay, I'm not talking that is rest of India. I'm telling ours is the rest of India and yours is the something which is very different. So the issues are totally different, and probably the support what they need to get for these diverse set of problems is also quite different. They are not there in the main programs actually. Yeah, what you are telling is absolutely right. You are telling about some constraint which is there, and probably yes, solutions for that to be addressed is a recommendation from your OR. Agreed. Yes, ma'am.
Very nice presentation, sir. Thank you for this informative session. One thing, as I'm from an academia, is there any need to add this operational research, something regarding operational research in UG curriculum? Maybe like this UG persons in future, they become the health managers and health program managers. And what about the inclusion of this, a little bit, at least a little bit of this in UG curriculum? What is your opinion, sir?
Okay. Before coming to that, let me tell, research in UG curriculum is still in nascent stage. Probably it is in embryonal stage. Okay, because that's not actually taken seriously by the medical students, neither by most of the institutions. Yes, there are good number of institutions who have taken this particular component, and we are not excluding operational research and telling that it's a different research domain. It's a part of research. Most of the principles of research which are there, which we are learning, we need to apply over here and build our OR protocols. So let us actually look at improvising the research component in MBBS curriculum. Probably along with that, if we have a sensitization to the students, yes. Okay. People from management disciplines, people from hospital administration, health management are very well aware of what is operational research, because they do that routinely in their practice, okay, in hospital admin, health management. But yes, I do agree that MBBS students can be actually given a sensitization program. Yeah, it depends on what how much time do you have to take up those in the in their existing curriculum. Yes, we'll move to the next. We are there available till the end of the day. So if there are any questions, queries, we can clarify over there. Yeah.
Thank you, sir. That was an insightful session.
Our next session is framing a research question, rationale, study objectives. I would like to invite Dr. Kedar Mehta. He completed his post-graduation at Government Medical and Education Research Society, Vadodara, and is currently working as the Associate Professor of the Department of Community Medicine at the same college.
He received Kalu Ram Memorial Award in 2018, Saroja Award in 2019, and Presidential Award in 2019 by Indian Association of Preventive and Social Medicine for his research activities.
He also received Medical Excellence Award for his outstanding achievements in the field of medical science at New Delhi in 2017 by Indian Solidarity Council. He was a recipient of Young Scientist Award 3 times by Indian Association of Preventive and Social Medicine.
So from an OR perspective, as she mentioned, either clinical practice or from public health practice, we will get some research question. But these three guiding principles we have. Broad idea of how to frame a research question in operational research, right? And what you all said were also correct. We can also find good research question from our patients, from literature, newspaper, from talking to colleagues, as she said, with seniors, other researchers, from attending conferences, from your teaching experience, from your guides, and of course from new technologies, right? So from all these aspects you can find a good research question, right? Now once I have selected my topic, how will I know whether it is a good or not? So we all will remember this criteria, which is final. I hope you have heard of this earlier. Yes? So quickly, I will not take much time, but quickly I will go through this. First is, F is that research question should be feasible. Second, it should be interesting. Third, novel. Fourth, ethical. And finally, it should be relevant. Right? So any research question should go through the checklist, whether it is feasible, interesting, novel, ethical, and relevant. Let us quickly look at these points one by one quickly. So feasible. Feasible to whom? First thing is feasible to us, right? You have this much duration to complete your dissertation, whether it is feasible to you or not, right? So the first thing is, it should be feasible to you. Second, it should have adequate number of study participants. Your sample size should be enough, strong enough, right? And they should be available and willing to participate in your study. Then you should have adequate technical experience. You should be trained in OR, right? You should know what are the principles of conducting OR. Then you would go ahead by conducting that particular study. Again, feasible in terms of time and cost. Suppose that testing costs me very high and I don't have enough funding, then it is not feasible for me to do that particular research. And it has a testable hypothesis. So the key point is we should keep it simple and we will keep it focused. We'll look at this when I'm going to take some examples, right? So the first point is it should be feasible. Interesting to whom? Once again, interesting to us first, right? We should feel that this topic is interesting, then we are going to do on that particular research on that topic. So first, it should be interesting to the investigator. It should be interesting to your peers, to your researchers, right? To the scientific forum. That topic needs to be interesting. Of course, it should be interesting to the journal editors if you feel, to the possible funders, and lastly to the policy makers, because OR, as Dr. Akshay mentioned in the previous session, that finally the end product or the end result should be, there should be some change in the policy level. Don't think of a very high or national level policy change. Even a minor policy change at your institutional level can also be an operational research, just at an institutional level also. Like I'll just give you an example, that we have a separate queue for X-ray for TB patients. Just we have that stamp thing. That stamp thing is there for TB patients. That means they will be taken, they will be given priority as compared to other patients. So that chest X-ray has been on priority basis. So this is just a minor OR. Change kahan pe hua hai? Change at the local level or just at an institutional level. So that can also be an operational research. That long waiting time, so then patient was not coming for chest X-ray, right? And delay in diagnosis, that was the constraint. And my programmatic objective is that TB patient as early as possible. And constraint is delay in diagnosis at a tertiary care hospital. So the three things, there was lack of tool, lack of knowledge, lack of tool or intervention, or inefficient use of tool or intervention. So here, there was no any intervention. So what we introduce the intervention just by putting a stamp that this is high priority presumptive TB patient, so that has to be given prioritized as compared to other patients for looking for chest X, right? Novel. What does novel means here? It can be altogether a new, but what does novel means? Something which is already existing and you are adding something new to that existing body of knowledge. Something is already there, but what is new? You should add on that particular body of knowledge. Don't repeat the same study. Right? Repeating the same study is like a Me Too study, but that has no role in OR. Right? What is adding new to that particular domain? That is very important. It can be first ever study on this issue. कोई study हुआ ही नहीं and first time I am doing this UDST. So UDST is a new thing and I am doing that. So that is a first ever study. Second is first ever study in your setting. Like I have done in Gujarat. She started to do in Mizoram in Northeast, and it becomes a first study in that particular setting because geographical location is different, right? Cultural factors are different, social factors are different. So it becomes first ever study in that particular setting. You do it in Wayanad, it becomes a tribal district in southern part of the country. That again becomes a first ever study in that particular Wayanad district, right? So that way it becomes new. Okay. So as I said, in terms of geography, in terms of population served, you can make your first ever study in the setting. And improving the methodology of the previous study. Say for example, your colleague or your senior has done some research and they have listed these were the limitations in my study. मैं इतना नहीं कर पाया. So now what you can do is, how can you make it new? You can make that limitations as your opportunity and try to add on those limitations, improve those limitations, and you can go ahead in conducting that particular study. Is it clear this point? So this is how we can make our research question novel. Something which I missed out, you are adding in your research project. So that becomes a novel or new thing. Of course, it must be ethical. We are all aware of this. So I will discuss much. It should not harm your participants. Right? It should have the maximum benefit to your participant. And every OR also needs to be approved by your institutional ethics committee. And finally, it should be relevant. Right? Relevant in terms of whether it is influencing the practice guidelines, it is influencing the health policy, or it is advancing the scientific knowledge, or finally it is guiding the future research. I mean, it should be relevant to the program. Simple. Right? Let us keep it simple. It should be relevant to your national health program. Maybe it's TB, maybe it's HIV, maybe it's non-communicable disease, any disease. If you say, it should be relevant. So, what were the characteristics of a good research question? Fine. Right? Feasible, interesting, novel, ethical, relevant. Okay. So that makes my research question good. Now, if you say that you told me these are the characteristics, then how to frame a research question? How to make a research question good enough? Right? कैसे frame करना होगा? How to frame a research question? So let us look at some examples, and then I'll give you the step of conducting or making your research question, framing your research question. Right? Just have a look at these questions and tell me how they are different, right? Say the first question, what do you understand by this? What this research question is? Yes, anyone? What do we understand by this? Or what I am trying to find out? What is my research topic? Yes? What's the outcome?
With an early ARV, what is the outcome among the TB patients having HIV?
Yes, right? But it took a long time to understand. Yes? So what she said is there are HIV in fact was very broad or vague, whereas this becomes very specific and focused. Right? It is very focused, it is very specific, focused in terms of, as I mentioned about, time frame is very clear and outcome is very clear. Right? So this is how you should frame your. But of course, you can't come up directly with this question. First question that comes in your mind would be a broad research topic. कि मुझे ये करना है, I want to do this research. But when I narrow down, and how you will narrow down? It will be based on a literature search. कि early किसको बोला हमने? Early ART is first 2 weeks, right? And late ART would be after 2 months. तो ये हमने definitions, operational definitions बोलते हैं इसको. These are known as operational definition. Means how will I label them as early ART and passive? Right? I'm making it very focused. I'm making it very specific. Now here my question is very simple. Only see, I've restricted my population to first episode of acute MI. Right? Then statins led to higher survival rates versus I have comparison as placebo. I also have a comparison group where I am comparing which is better. Right? Does watching TV causes obesity? Right? So I am not clear about who. Right? So now it becomes very clear. Right? In school children, if increased TV viewing, what is that increased TV viewing? More than 4 hours per day, associated with an increased incidence of obesity. I am not talking if the child is already obese, no. Increased incidence of obesity as measured using body mass index compared to moderate TV usage of tuberculosis. So, as I said, your initial question would be very broad, don't worry, right? But the challenge is to, right? The challenge is to, yes. So the challenge is to focus it and keep it as simple and as specific as possible, right? That is the main bottom line. So how to do that now? आपने बोल तो दिया कि इसको focus बनाओ, specific बनाओ. कैसे करेंगे वो? So you all have been, this is the second acronym from the session, PICO, right? This is the second acronym. The first was FINER and the second is PICO, right? Have you heard of this earlier? Yes. So that is very simple. P stands for population, amongst whom I want to do this study. I stands for what is the intervention here, right? What is the issue of interest? C stands for comparison group. If you have, it is not necessary always, but if you have, it is better. And the last is outcome. What is the outcome of it? And T stands for time frame. This sir picked up in the first thing. Right, the time frame was very clear in that research question. Clear? So, it is not needed always, but if it is there, it is better. So, PICOT, this is the format of framing any research question. You should have what in your research question? Your population, your intervention, your comparison, and your outcome. Right? So can you tell me in this question what was the population? Only adult patients? One at a time? Yes, please. Very good. Adult patients suspected to have pulmonary tuberculosis. That is my population. Then, what is the intervention? PCR. Okay. Then, what is the comparison? Mycobacterial culture in liquid media. Yes. And what is the outcome? Sensitivity and specificity. Right? So this is how I make my research question in this PICO form. Now let us take some examples. Okay, I am not going to detail, we have already understood this. Can we make it more specific or more simple? What I am writing, zinc, is zinc effective in treating cold? What is missing here? Population is missing. There is no comparison. Right? Outcome is also vague. Right? So, population, intervention, only two things are there. Problem we know, that is not population, that is problem. And intervention pata hai humko, zinc, right? So So what is the population here? Children with common cold. Intervention? Oral zinc, that is for 5 days. What is the comparison to? Placebo. We have not given anything. Common cold we have, right? And outcome is reduction in the duration of symptoms of cold, right? Fine. So population, this is the problem, this is the intervention, placebo is the comparison, and duration of symptoms is your outcome. Now that was some therapy question, research question related to some therapeutics. Now some question related to etiology. Exposure to benzodiazepine in pregnancy and malformations in the newborn. Anybody wants to try? How can we frame it? What would be the population here? Pregnant women who are on benzodiazepines. Clear, right? And what would be the outcome? Malformations in the newborn. So is the pregnant women who have been exposed to benzodiazepines, what they are more specified? During early pregnancy, cause malformations in the newborn baby. Right? So this is my population and this is my outcome. It is not necessary to always have some intervention and always have some comparison. Are you with me? So here you may or you may not have. So there is a question mark, but your population and outcome should be there, right? So what I mean to conclude is descriptive studies sometimes may have only 2 components in the research question. Which are those? Population and outcome. But these 2 are mandatory. You cannot have any question without population and without outcome. Right? Sometimes it is not possible to have population, intervention, comparison and outcome. In that case, descriptive type of research questions, we may have only population, outcome or population, outcome and time frame. Right? In observational studies, as I said, there is no intervention. Sometimes there is no comparison or there is no intervention. I just want to compare. I just want to look at the intervention. Right? Let's say for example, here I don't have any comparison group, right? I don't have any intervention. I just want to see that what is the effect of not getting drugs, right, amongst TB patients. What is an outcome? So simple. I have population of TB patients not receiving any medication or not receiving timely AKT and their treatment outcomes. So I have only 2 groups. I have only 2 components. Sorry, population and outcome. Right, and I can define the time frame. Within these 2 months, those who have not received AKT or those who have not started anti-cox therapy within these 2 months due to non-availability of drugs. So that becomes my research question. Right. More example, see operational research example. Among HIV-infected people registered in 2023 in ART centers in Calicut, Kerala, that becomes my now. This is 2-line big population, very clear. HIV-infected, registered in ART centers of Calicut, right? Kozhikode ke jitne bhi ART centers hai, sab mein, right? How many HIV newly infected, registered, right? In Kerala, what are the proportions who were screened for TB and diagnosed as TB? Now this goes with the objective of the program. NTT का objective क्या है? All HIV infected individuals should be tested for TB and all TB should be tested for HIV. That is a bi-directional screening, right? So now I want to see whether I want to identify the constraint. इसमें कुछ constraint आ रहा है कि नहीं है? So for that, identify that constraint. What I should have some baseline data. So this would be the baseline data to find out whether all of the HIV individuals are screened for tuberculosis, and out of the screen, I also want to find out how many got diagnosed as TB. Right? Still, I want to extend further. कि मेरा 1.5 साल का project अभी भी चल रहा है. What will be the next? Yes, completed. So screened, second step is diagnosed, third would be treated. Out of them, how many could get complete treatment? So this is how you can have a cascade, right? Cascade of services. You looked at all three aspects. How many were screened, how many were diagnosed, and out of diagnosed, how many were treated, right? And out of, again, still I want to go one step further. Successful outcome, right? How many had successful TB treatment outcome amongst this ELHA, right? Clear? So you are now getting in the mode of operational research. Everyone? Yes, we try to find out the program objectives, we try to identify the constraints, and then frame our research question around that constraint. Looking at which components? E, I, C, O, whichever is applicable. Yes, T, time frame, right? So this was population outcome, and this was time frame, C, right? Another, among patients with confirmed COVID disease who received hospitalized care during 2022-23, what are their treatment outcomes? Very simple question. I have only two aspects, population outcome, and what is the third component? Time. That is during 2022-23, right? I can make it like this also. And this is probably the last example. What is the trend in treatment outcome of health workers with TB in India over 10 years? So what is my population here? Health workers with TB who are working in India, right? Time frame 10 years के time frame मुझे देखना है, and what are their treatment outcomes, right? Now once I frame my research question, I'll frame aim and sometimes your why would also start with that, right? What was the aim of your destination? Right. So to quickly make it very simple, as I said, we don't use jargons. We try to make it as simple as possible so that it becomes easy for understanding. When you frame the research question, when you convert that in the form of a statement, that becomes my aim. Simple. I want to convert my question in the form of statement, then that becomes my aim. So what is the aim here? To estimate the proportion of TB among HIV. That becomes my broad statement. Now when I put it in the form of pieces, or when I make it measurable thing, that becomes aim would be converted to objectives. So say for example, my aim is to climb a hill and I want to go to that particular place at the top of the hill. So what would be my objectives? The stairs which I am going to climb, and I reach that particular spot. So that climbing of staircase would be what? Objectives. So aim would be one, but there could be many objectives to reach that aim. Are you getting it? Right? To reach there, I have to climb these 5 steps. So these 5 are objectives, and my aim is I want to go to the last row. Simple. So my aim is one, but I have to make sure there are many objectives to reach that particular aim. Right? So let us take one more last TB example to have this concept clear. So aim is a broad statement of the desired outcome or general intention of the research. It is nothing but the research question rephrased as a statement. Once you frame your research question, you phrase it as a statement, that becomes an aim. Objective is a clear and specific statement that needs to be accomplished over a period of time in order to achieve aim. Right? So, third acronym of the day, and then this is the last one, right? Don't blame me, but this is the last one. The third and the last acronym is, your objective should be smart like you, right? So what does this smart means? S is, it should be specific, it should be measurable, it should be achievable, it should be realistic, and it should be time bound. So in the further session, Dr. Akshay sir will let us know for every objective we would have ये कहाँ से मिलेगा data, ये कैसे measure करोगे आप, because you want to make your objective measurable, right? So वो कैसे आप बनाओगे? So for that you should have your objectives very very specific and it should be measurable. I'll give you an example so it would become more clear कि objectives कैसे बनाने चाहिए. Say for example in the previous वो हमने देखा HIV individuals, infected individuals ART center में registered है. So what would be the objective? To find out, the first thing is number of PLHIV screened for TB. That is first. What will be the second objective? Among screened, number of PLHIV diagnosed as TB. Third objective would be number of out of diagnosed, number of PLHIV infected with diagnosed with TB, how many were treated. So this is how you make some step. And the last objective could be the factors associated with all these things. कि male में ज़्यादा था या female में screening अच्छा था. What are the other education status? What were the occupational status? Other factors, comorbidities की. So these all becomes factors to find out the factors associated with screening, diagnosis, and treatment. All that you can combine and make it the fourth objective. Right? Is it clear? So this is probably the last example to understand aim and objectives. So what is the aim here? To describe the management and treatment outcomes of smear negative pulmonary TB patients in India. So this is a broad statement. Yes, it is a broad statement. Objectives now would be, have to make it more specific, and it starts with the STEM. The STEM is the population, always. Right? So what is the STEM here? In a country-wide audit of, what is the population? Sputum negative pulmonary TB patients registered in 2023 in India. So I have my population as well as my time frame. Everything as a STEM to start my objectives. Now we will look at one by one step. First, to find what? पहले क्या देखेंगे? Yes, how many sputum negative are there? So the first is number or proportion of sputum negative pulmonary TB amongst all TB patients. Right? Out of 100, say for example, TB patients, 20 were sputum negative. So that becomes my first step. Right? Because I want to look at smear negative pulmonary TB patients. That is my aim. तो पहले तो मुझे पता होना चाहिए कितने हैं out of all TB patients, how many are SNP TB patients. Second is, what else I'll do? ये जितने हैं उनका क्या करूँगा मैं? Their demographic and clinical characteristics. Third objective is number and proportion, उसमें कितने multi drug resistant TB है. And lastly is their TB treatment outcomes. इस sputum negative pulmonary TB में कैसा treatment outcome है and association with which factors? जैसे I said just now, clinical and demographic, कि delay in time था, delay in diagnosis था, तो उसका effect कुछ treatment outcome पे आ रहा है कि नहीं आ रहा है. That becomes my fourth objective with focus on treatment failures. इस sputum negative pulmonary TB है, तो which are the factors? Right? What is the problem here? Why उसमें treatment outcome poor है? So the objective of TB program, once again coming back to NTEP, is there is treatment failure among sputum negative pulmonary TB. Right? Our objective है कि हमको सबका treatment rate we want good enough. The objective, that is a broad objective of NTEP program. Right? And but this is a constraint. Constraint कहाँ है? Concept group of patients में sputum negative, smear negative pulmonary TB में. So for that this OR could be planned. What are the audit can be done of all this sputum smear negative pulmonary TB patients. Right? Remember this one more point. Too many cooks spoil the broth. Similarly, too many objectives will spoil the study. So don't make 10, 11 objectives in your dissertation also. This is a common advice. Forget about OR. In general also. In your dissertation, don't give 11, 12 objectives. No, restrict it to 4, 5 max. Because he will explain in the next hour. जितने objective डालोगे उतना काम बढ़ने वाला है. The more the objective, your work is going to get more and more hard work. Right? So, lesser is better. Right? Please go with this trendline. Right? जितने कम objectives है. Why? Because we want to keep it simple and focused. At the end, we are giving an answer. Right? So we want to keep it as simple as possible, and we need to keep it focused. Okay. So to summarize, research question is the most important component. 3 acronyms. First was your research question should be final, right? Feasible, interesting, novel, ethical, relevant. It should be written in Ephacon format, population, intervention, comparison, outcome, time frame. Right? And your objective should be SMART. Specific, measurable, achievable, realistic, and time-bound. Right? So, I hope how to frame a research question, how to make it good enough, right? And finally, based on research question, you should have aim and objectives of your study. So this is the first step of OR. In operational research or any research, सबसे पहले यही करना है आपको. ठीक है? Research question frame करना है और aim बनाना है और objectives बनाना है. Don't worry, you will have some hands-on exercise also. We will be giving you some topics. Try to frame a research question related to OR, right? Because we are in the OR workshop, so make sure that we have some operational research questions coming up from you, and then your peers will also comment कि नहीं इसको कैसे specific बनाओगे? How can you keep it more and more simple and focused, right? So that's it. Thank you all and for the attention. If Akshay sir wants to add anything to the research question, right? So thank you, everyone. We will go to the next one. Thank you.
Thank you, sir.
Questions, I think, if any, we will take afterwards. Right. Thank you.
Thank you, sir. Your insights and perspectives are invaluable to us.
I hope you have been finding the discussions insightful and engaging. Now it's time for a brief break to recharge our minds and bodies.
After the break, we have the inaugural session. We will have a session on operational research after the inaugural session, for which all the participants have been divided into 6 groups. Kindly find which groups you belong to according to the list displayed in front of the Sapphire hall, as well as in our Ephacon 2024 group. And please return after the break and be seated accordingly in front of your displayed group numbers on the respective tables.
We'll reconvene in 15 minutes for the inaugural sessions. During this break, feel free to visit the refreshment area where you will find an assortment of teas and light snacks to enjoy. Please remember to return promptly so we can resume our agenda without any delay. Thank you and enjoy your break.
Hello. 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 Check. Hello. Hello. Check. Hello. Hello.
Hello. Hello. Good morning, everyone. With immense pleasure, I welcome our distinguished guests, esteemed speakers, and respected delegates to the inaugural ceremony of Ephacon 2024. I request our Professor and Head of the Department, Community Medicine, Malabar Medical College, to escort the dignitaries onto the dais. To grace the dais, we have with us today our esteemed chairman, Mr. Anil Kumar V, our respected principal, Dr. P.V. Narayanan, our secretary and director of medical operations, Dr. Sudha Anil, vice principal of postgraduates, Dr. Paul O. Raphael, and our organizing secretaries, Dr. Kanyan Binoob and Dr. M.A. Ramachandran, associate professors of Department of Community Medicine. I also invite Dr. George B. Jacob, professor and head, Department of Community Medicine, onto the dais. Now let's seek the blessings of the Almighty with a prayer song by Ms. Anushri, our medical social worker.
ലോകം മുഴുവൻ സുഖം പകരാനായി സ്നേഹദീപമേ മിഴി തുറക്കൂ. ലോകം മുഴുവൻ സുഖം പകരാനായി സ്നേഹദീപമേ മിഴി തുറക്കൂ. കഥന നിവാരണ കനിവിന്നുറവേ കാട്ടിൻ നടുവിൽ വഴി തെളിക്കൂ. ലോകം മുഴുവൻ സുഖം പകരാനായി സ്നേഹദീപമേ മിഴി തുറക്കൂ.
On behalf of the Department of Community Medicine, I am honored to introduce a key figure who has been instrumental in steering the direction of our department and contributing immensely to the academic and professional landscape. He has been a beacon of knowledge and inspiration for both students and faculty alike, and is known for his approachable nature and unwavering dedication. It's my honor to invite Dr. George P. Jacob, Professor and Head of the Department of Community Medicine, to deliver the welcome address.
The function of education is to teach one to think intensively and to think critically. Intelligence plus character, that is the goal of true education, as said by Martin Luther King Jr. Respected Chairman, Mr. Anil Kumar, Principal Dr. P.V. Narayanan, Secretary and Director of Medical Operations, Dr. Sudha Anil, Vice Principal Dr. Paul O. Raphael, heads of departments, faculty, delegates, our esteemed resource persons, administrative staff, interns, and students. A very good morning to all of you. Today, we have gathered here to discuss about a problem responsible for about 1.5 million deaths every year. Today, we are gathered here to gain more understanding and thereby become better prepared to control a disease that is responsible for making more than 10 million people fall ill every year. Today, we have gathered here to learn and to share our experiences in managing tuberculosis, the world's top infectious killer. This conference was conceived as a platform to disseminate knowledge and share the rich experiences of our esteemed resource persons, and also to give young researchers a chance to present their scientific findings. I stand before you to extend a very warm welcome to each one of you to this national conference on behalf of Malabar Medical College, Kozhikode, and its Department of Community Medicine. I deem it my privilege and honor to welcome our chairman, Mr. Anil Kumar V, to this function. Sir, we value your esteemed presence very highly. We look forward to you for guidance and advice. A hearty welcome to you, sir. Dr. P.V. Narayanan, our beloved principal, has been a great source of encouragement and guidance for all the departmental activities. Sir, I feel honored in offering you a cordial welcome. I wholeheartedly welcome Dr. Thomas Matthew, Director, Medical Education, to this conference in his absentia. Though Sir could not be physically present today, he was kind enough to send us his message and best wishes. I extend a cordial welcome to Dr. Sudha Anil, Secretary and Director of Medical Operations, to this inaugural function. Madam, we are honored with your presence. Our Vice Principals, Dr. Paul O. Raphael and Dr. Rajesh, are providing the necessary support and encouragement to us. Dr. Paul is with us this morning. Sir, I wholeheartedly welcome you to this inaugural session. Our Medical Superintendent, Dr. Ravindran, is supportive in all our activities. Though he is physically not here now, we extend a cordial welcome to him also. I take this opportunity to extend a hearty welcome to all our esteemed resource persons. We are eagerly waiting to hear them. With great happiness and joy, I am welcoming our delegates to this conference. It is you who have made this conference a meaningful one. A welcome to each one of you. I extend a cordial welcome to all the respected heads of the departments and faculty of various departments who have spared their valuable time to be with us this morning. I thank each and every one of the respected faculty. I also welcome all the administrative heads and all non-teaching staff who have given us wholehearted support and are with us this morning. I take this opportunity to welcome Dr. Kanyan Binoop and Dr. Ramya Ramachandran, organizing secretaries, and Dr. Shilpa Karir and Dr. Krishnaraj J.S., joint secretaries to this conference. I sincerely offer a hearty welcome to all my other colleagues in the department who have toiled hard for months to make this conference a reality. Let me offer a hearty welcome to each one for you once again. Thank you. Thank you once again.
Thank you, sir. It's our privilege to introduce our respected principal, Dr. P.V. Narayanan, whose relentless commitment and dedication serves as an inspiration to all of us. On behalf of the organizing team, I invite you, sir, for the presidential address, offering us your invaluable guidance and wisdom as we embark on this journey of collaboration and discovery.
Our most respected chairman of Malabar Medical College, Mr. Anil Kumar, Secretary of this association, Dr. Sudha Anil, heads of departments, Community Medicine, Dr. George, Vice Principal, Dr. Paul, Ramya, Dr. Kanyan Binoop, secretaries of this organization, for this organizing committee, our national member for tuberculosis and the head of Department of Pulmonary Medicine, Dr. James, other dignitaries, invited guests, speakers, and most valuable persons of today, our students coming for this CME program. A wonderful program in the sense with a national importance. We are conducting this, and I once congratulate the organizers, especially the HOD, George Joseph. For the last 1.5 months, he is behind this program. He came with this idea, whether we can start a national conference in this college. I told you can have all the power, you have all the facilities in this institution. To start with a national conference, it is not a simple procedure. To get eminent personalities, speakers from, when you go through this, you can see the speakers are not simple persons. They are with this much caliber and resource personalities from world over. So to collect such persons and coming here and getting such a wonderful CME program. Really, I congratulate the organizing team. Our chairman's vision is not to make our students for today's necessity. Today's problem or today's solution will not be a solution for tomorrow's problem. So make our students with a vision that for the coming years, they will be a resource person to solve all the problems. Tuberculosis, when we were students, we usually study, or we are supposed to study only few relations with the tuberculosis. At that time, there was no department, a separate department for tuberculosis. Only pulmonary medicine, and we usually, in the Calicut Medical College, there is no division, only in Beach Hospital. Those who are away from the college, those in the Beach Hospital, we usually get the exposure from that Beach Hospital only. Now, a whole department is set, pulmonary medicine with the MBBS, MD, DM. So that is the development of pulmonary medicine, who deals with this tuberculosis. And simultaneously, tuberculosis also is developing. Wonderful. So we have to think whether we can stop it or not. Polio we stopped almost. So many communicable diseases we stopped. Why this community medicine people are not stopping this tuberculosis? I want to ask them. What they are doing for the last so many years? We have to get an answer from this CME. Whether they can stop it. I think George is aiming that. We want to stop it with this, and you all can take that challenge. WHO, today, what is the date? What is the importance of today's? WHO is giving a date. What is that importance? World Blood Donors Day. Blood Donors Day today. So you all have exposure to that. To save the life of many. Today we are in grief. Malayalis are in grief. Why? 49 people, Malayalis, died in a accident in Kuwait. So, but everywhere, death is everywhere. War is taking, disease is taking. So the life, there is a solution, because the God has created more creatures and He wants to wipe off this. So tuberculosis. But this disease, King's Evil. Have you heard King's Evil? Anybody? I will give a prize. King's Evil? Or I will at least ask our Kenyan Binu to give a prize. King's Evil, the first, I think he can, he's the surgeon here. A nodule on the cervical region was given the name King's Evil because the first Profola signed and gave this name, because when the king is in the UK, they thought this will be cured by the king's touch or the king's family if they touch it. Even now we are having some areas where you touch, the disease will go. So the kings, if they touch it, then that gradually goes. That is the cervical node, tuberculosis node. And from there it starts. Now extra, our Durga is here, another very important person who is spreading the disease. Controlling the disease. She started so many activities. Durga is the professor in pulmonary medicine. She is the nodal officer here for preventing, controlling tuberculosis transmission. But she says, now the pulmonary cases are less. Extra pulmonary cases are very high. I had an opportunity to see a driver who usually neighbor who comes for any help, swelling here, and was reported as lipoma. Every time he comes, whether this lipoma can be removed like this. Lastly, I told you go and have a FNAC. Thought again report came as lipoma. Excision. Ashwini Rajalakshmi madam told you do an excision and biopsy. Finally, he agreed for that. And Calicut Medical College, last month, he went for excision biopsy. and it was taken about a big swelling here, but there is a caseating material inside. So for the last so many years, he is going with this lump, and that came to be a tuberculous node, caseating material. So extra pulmonary tuberculosis is spreading, and in so many ways, whether it is skin or tissue or bone. So be careful. We have to spread. When we are controlling in one side, this is exposing in other ways. So this community medicine department, what their theme, I think it's very, very essential at their days, very important. Our speakers, sir, I can see so many faces here. WHO experts are here. I think they are from Mizoram. Yes, because you cannot. So we respect you, madam, from coming from Mizoram to Kerala. This is a wonder for us. This is God's own country, madam. You can see so many gods here. See, our chairman is a god, and born as a normal man with a normal vision. He came out with a vision surprisingly. Amma, you heard Amma, Amridandamay Amma, born as a son. Now she came as a divine. Like that, he came out as an entrepreneur with a vision that he wanted to create a medical college here, in this hilly area, identified. And this is the one private medical college with 150 seats. In all Kerala, only 100 seats they are providing. This college got 150 seats because of his vision. Then it came out as 200 seats now. Again, in private institutions, this is the first medical college with the 200 seats. Again, we are having only 14 years of existence. We got more than 50 PGs in this institution, 50 PGs. Our MBBS students in Kerala University of Health Science got first rank. Not first rank. This is one mark less. She got only second rank. So still we want to be proud that we got first rank. But in PG, postgraduates, dermatology, we got first rank. The first instance, first chance. So our teachers are majority from Calicut Medical College. That is the government institution with 250 seats. That is the first institution in Kerala with the 250 seats, where I was the principal at that time. So I am happy to announce that with that we got 250 seats. I retired from there and came out. So my vision and the principal chairman's vision is same. He want to increase the seats. I also support him. So we are trying for that and hope. Today also we are waiting for a NMC virtual meet. Yesterday we went there, sat up to 5:30, so they vanished. Today we suppose they are coming for sanctioning DM cardiology and DM gastroenterology. So we are behind that. We want to make it perfect. So please pray for that. I am just going back again. We want to get it. Definitely our chairman's vision is like that. So he is a symbol, and you can go and get anything from him if you want. But you have to travel in such a speed, not in a normal speed, high speed. Then only you can reach behind him, not along with him. So that is the caliber, and this college also set up like that. I don't want to take much of your time. There is a usual saying, a learned man will talk for he want to give some message, something to say. Or a layman will say a message. Say something. Say something. So we are here to say something. And the learned people are sitting there for giving a message, something to say. So hear from them what they are going to say for you. Take the message and you incorporate in your life. Then you become a masters in this field. Community medicine, now it is given the most important topics from the first year to last year. So they are tapering and they are forming the students. And I think community medicine, whatever fault is there, it is with the community. Whatever the fame is there, it is with the college. So I congratulate once again the organizers for conducting such a wonderful meet. And again, I congratulate the WHO people, the learned resource persons for addressing our students. So they will get some benefit. Thank you, sir.
Thank you so much, sir, for those inspiring words. We'll now have the lamp lighting ceremony to mark the illumination of knowledge and spirit of unity. I kindly request all the dignitaries on the dais to come forward for lighting the lamp. Thank you all. Today, we have the distinct honor of receiving a message from the Director of Medical Education, Kerala, Dr. Thomas Matthew. He is a beacon of excellence and is innovative in the field of medical education and healthcare administration. His dedication to advancing medical knowledge, the next generation of healthcare professionals, is unparalleled. Because of official commitment, Sir is not physically present with us today. So let's hear the recorded message from the Director of Medical Education, Dr. Thomas Matthew.
Principal, Malabar Medical College, Sri Anil Kumar, Dr. George P. Jacob, Dr. Kanyan Vinoob and the team members of the organizing committee, and our respected faculty, teachers, students and friends. It's with immense pleasure that I take this opportunity to congratulate the team who has put up a very topical national conference, Ephacon 2024, Enhancing Public Health Acumen, with the theme of TB Chronicles, Lessons from the Past, Insights for the Future. All efforts in teaching and training in TB prevention, treatment, we are all aiming for a control, for elimination and ultimate eradication of TB, which may not be in foresight, but we are all looking forward to efforts to curb the menace. TB, which is one of the partners of crime as it was known earlier, along with HIV, then poverty, and then diabetes and other non-communicable diseases. TB is still there, and it is the duty of each public health activist, public health worker to see that all efforts are made to bring down the incidence of TB as well as reduce the mortality and morbidity due to the disease. And I take this opportunity to congratulate the team for taking this as the mainstay of this national conference, and also place on record my deepest appreciation to the faculty as well as the participants who are taking part in this process. And a lot of other subjects and other areas are also being covered in this national conference, including operations research, then paper presentations. I wish all the best for this program, and I declare this national conference open. Thank you.
We are honored to have with us today our esteemed chairman, Mr. Anil Kumar V. He is a visionary leader who has always wholeheartedly supported us for all our endeavors. I invite you, sir, to share your valuable words with us.
Respected Principal, Dr. P.V. Narayanan, sir, HOD of Community Medicine, Dr. George P. Jacob, Vice Principal, Dr. Paul Raphael, Dr. Kanyan Binup, Dr. Sudha, my spouse, and other dignitaries on the dais, off the dais, respected faculties, resource persons and speakers, delegates, a warm good morning to every one of you. I really congratulate the Department of Community Medicine, their HOD and the team members for having chosen such a topic which will, as the principal rightly said, which will get you some insights as how to control and prevent tuberculosis, which kills at least 1,400 humans a day in our country. Although, as said, we have been trying, once upon a time it was said to be eradicated, then again come up in huge numbers. And I believe our James sir is been taken to the Central Committee members of TB when our institution is going to host such a program. Of recently has been elected to the Central Committee of Tuberculosis Prevention, and we are honored to have his presence also here. He will also address you the various measures, means and all that from the Department of Pulmonology to control TB. I'm told that many resource persons from WHO and from various parts of the country have come here to address you. I wish this program all the best and wish the delegates a good feast which will give much insights while you go ahead with your profession. Community medicine is rather known as preventive medicine. As again principal said, the role of community medicine, the importance of community medicine is felt more in the current situation when the country is finding it difficult to curb the communicable diseases. The preventive measures to be taken from the fraternity of doctors, the lessons to be taught to the public about various measures. So the Department of Community Medicine take the pride in ensuring that the public in general are taught about the preventive mechanism to be in place and all that. So once more wishing you everything best. Thank you.
Thank you, sir, for your influential words. We are overwhelmed to release our Ephacon souvenir, which captures the essence of our conference. I humbly request our esteemed chairman, Mr. Anil Kumar, to release our souvenir. I invite our souvenir committee chairperson and associate professor, Department of Community Medicine, Dr. Shilpa Kari, to hand over the souvenir to chairman. We are glad to have with us today our Vice Principal of Postgraduates, Dr. Paul O'Rafale. His journey of perseverance, dedication, and achievement serves as a beacon of inspiration for all of us. I invite Dr. Paul to share a few words with us.
We need to leave for the inaugural session of our renovated bank. We are all invited guests there in connection with the inauguration of the renovated blood bank, wherein the DMO is waiting. So kindly excuse us for leaving the place. Thank you.
Respected Chairman, Principal, the Head of the Department of Community Medicine, Dr. George Sir, the Organizing Secretaries, Binoob and Ramya, the faculties who have come to present, and also the faculties of this department, of all the departments here. James sir, very happy to hear that you are elected as a national dignitary to the tuberculosis. We were very proud to be a part of the hospital from which he is elected. PGs, postgraduates, I don't think any students are here. Okay. Welcome to all of you, and good evening. I'm supposed to tell about the felicitation. I am supposed to felicitate. To begin with, let me congratulate the whole team, George sir, Binoob, Ramya, and the whole of the team. I think it is the community medicine is one of the biggest department. If you see number of PGs, they are the most luxurious department here. Yes. So it is something good. And regarding the number, I am really surprised to see the number of people who have come. It's really nice, and I hear that we have representatives from the WHO also. So it is really great, and one thing is sure, it is because of the great organizing, the quality of the academics, and the teamwork you have. So please join me to have a big applause to the whole team. CME, like you all may be thinking that CME is something, it is for the postgraduate. It is not at all. As my mentor, what principal used to say, that there are many things to learn. Then you have to unlearn and relearn and be a lifelong learner. So if you ask me whether I have learned today something, yes, I opened the stream, live stream. That's also actually, it was very helpful that you have live streamed it also. So even during our busy time, after giving anesthesia, like I opened this, and it was operational research by Dr. Akshaya. And I could learn something, that there is something called operational research. And the next was about the framing the question from Dr. Kedar. And in that, the objectives and many things you understand, you would have studied before, but it may have changed. So you should be ready to, even at any age, you should be ready to unlearn ourselves and relearn. And today, from the stage, from this, also you learn something about King's Evil, what principal was saying. So that is something great. And I wish all the best to the team, and as well as I know that it will go on very well. And thank you very much.
Thank you so much, sir. Now I request Dr. Kanyan Binoob, Associate Professor, Department of Community Medicine and Organizing Secretary, Ephacon, to share a few words with us.
Respected Vice Principal Paul O. Raphael sir, our HOD Dr. George P. Jacob, my colleague and colleague for organizing and the backbone of the conference, Dr. Ramya, my team, respected HODs, especially we have James sir here, forensic HOD, and all the other HODs, professors, faculty, the great resource persons, and my dear colleague and delegates. I am delighted and overwhelmed to see some familiar faces. We have Dr. Anish there, we have Dr. Sheelu, and so many prominent faculties, and extremely great personalities from different sections of the nation. The theme of this academic feast, Ephacon, it's actually an attempt to explore tuberculosis from historical perspectives to the current opportunities of operational research. Yes, let's join together to explore cross-cutting edge research, innovations, recent advances in diagnostics, unusual presentations, adverse drug reactions, effective preventive and treatment strategy to combat this deadly disease. And thank you once again for being part of this conference. And if you need any help, we are always at your service. We wish you 2 fruitful days of academic feast together and aspire a pleasant stay in this serene campus. And surely you know about Kozhikode. It's a wonderful city. Please explore. Thank you. Thank you.
Thank you so much, sir. Dr. Ramya Ramachandran, Associate Professor, Department of Community Medicine, and the Organizing Secretary, Ephacon 2024, has been the driving force behind the seamless execution of this conference. With exceptional organizational skills and an unwavering commitment to excellence, she coordinated every detail, ensuring that today's event is both enriching and memorable. It's my privilege to invite you to deliver the vote of thanks on behalf of the organization committee.
Good morning, dear all. We have got a very beautiful tea counter, a Sulaimani counter arranged for you. And I know you have all been itching to go there and take photos and everything. But kindly bear with me for maybe 3 to 4 minutes. Okay? Thank you. So, as we conclude the inaugural ceremony of the Ephacon 2024, I would say that it has been a very, very long journey for the Department of Community Medicine. So, basically we started it off as a half-day CME, and then it became such a huge, fully fledged national conference that we could only have dreamt of 6 months ago. So, thank you all for your presence. So, first and foremost, I would like to thank our dear Dr. Chairman, Anil Kumar Valil, who has been the pillar of support for this conference, and if not for him, the conference would have been a dream, not a reality as such. I would also like to express my sincere gratitude to Dr. Sudha Anil, Secretary and Director of Medical Operations, for her sincere support, and her support has been crucial to the success of the program. I would like to express my heartfelt gratitude to our dear principal, Dr. P.V. Narayanan. Your constant support and encouragement has been invaluable. A special thank you to Professor Dr. Thomas Matthew, our Director of Medical Education, Kerala. He took time out of his busy schedule to provide us with an insightful recorded message. Your contributions are greatly, greatly appreciated. I am profoundly grateful to our vice principals. Dr. Rijesh P. In his absentia, I would like to thank for his extended support. Dr. Paul O. Raphael for your extended support and commitment. A very sincere gratitude, I should say, would be to Mr. Shafi PK, Senior Manager, Planning and Development. Your efforts and dedication have played a crucial role in the success of this conference. I think he is absent right now. I would like to thank my organizing team, particularly organizing chairperson, Dr. George P. Jacob. He is a professor and HOD of the Department of Community Medicine, and he is well known for his leadership skills, his principles, and he has been the guiding light behind this conference. I would like to take time out to thank the IT department, the PRO team, Shindo and Team Crop Circle, and the souvenir team for the wholehearted support, the logistics, and all support rendered. I would like to thank the class coordinators, Mr. Radhakrishnan and Mr. Benoit, for all services rendered. I would like to thank my dear colleagues, Dr. Sobin, Dr. Roshni, Dr. Swati, Dr. Shaki, for their support, moral as well as otherwise. Lastly, but not the least, I would like to thank my joint secretaries, Dr. Kanim Binob, Dr. Shilpa Karir, Dr. Krishnaraj, for their extended support. Thank you.
So with that, we have come to an end of our official inaugural ceremony. Thank you all for being here with us today. Let's together make this conference an unforgettable experience. The delegates are requested and the guests are requested to stay back. We'll be having a small photo session now. Okay, I think because of the lack of time, we'll break for tea now. The tea is served right outside the hall. So please enjoy the flavors of Kozhikode, and the delegates are expected to be back after 15 minutes to their respective halls. We'll be continuing with the workshop sessions. So please, the delegates, please hurry up. We are already running short of time. And please be back after 15 minutes.
hello, check. Hello, check. Hello, hello, check. Hello, hello. Hello, check. Hello. Hello, hello, check. Hello, hello, check. Hello, check. Hello. Hello, check. Hello. Hello, hello, check.
Hello, hello. Hello, 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 hello.
Hello, hello, hello.
those who have session in the MU hall, please proceed to the MU hall. Others can sit here.
Welcome back, and now we'll resume with our sessions. Please make sure you're all seated in your respective groups assigned to you. If you have any doubts regarding the same, please check in the Ephacon 2021-2024 WhatsApp group where we posted it. Our next session is on defining study participants, sample size calculation, and sampling technique. I once again request Dr. Akshaya KM on the dais to delve into the topic.
He completed his MD in Community Medicine from MS Ramaya Medical College with first rank in the university and currently is working as professor and head of the Department of Community Medicine.
Okay, thank you for that cut short introduction from my side. So, yes, we'll get into business because this is what we are expecting. So probably at the end of the day there are some couple of research questions which come up, and probably we should be able to give some comments and then take it forward from this particular workshop. Even though I don't call it as a proper workshop because OR workshop requires longer duration, so probably we'll be cutting short some of the sessions, but we'll definitely give you some time for working upon a couple of research questions and then presentations. So looking at what is study, who are our study participants and what are the different methods for sample size calculation and sampling in our ORs. So the principles of these three particular components remain the same as far as any other research is concerned, with some small minor differences here and there. But if you are reading these components from any of the standard good research methodologies textbooks, so you should be able to actually get to know about how to write these particular sections in any OR protocol or proposal. So as Dr. Kedar was telling, in PICO format, if you have to write, then there is something called as a population. So population is what constitutes in our on whom we are actually doing this particular study, and they can be divided into three different actually groups if you see, and they are hierarchical. So mostly the study population or study subjects or sample is what we call is drawn from the larger universe of the accessible population and then target population. So this hierarchy will tell you how these terminologies are different. Though, so the study population or subjects or sample is a small set or a subset of the accessible population enrolled in our study. This group is the best to which you can apply your conclusions. So most of the times we put a rider in our OR results or when we are discussing, saying that these are the programmatic settings only to which we can apply these particular results or the findings. So because we have done it under a small, in a small subset of a population from where we are taking this particular sample. So accessible population is geographically, remember, geographically or temporally available population, and it gives a practical representation of the reference population. So probably you can take an example of all patients who are registered in a particular quarter of a year in a particular district will form our accessible population. So probably geographically we can access all these people. However, logistically and with certain constraints, we will not be able to conduct the study amongst all these, and we try to get a subset from this particular accessible population. And if you want to generalize the findings to a large population, so that is what is our target population. However, if you have to generalize the findings, then you have to ensure that there is a proper methodology as far as sampling is concerned, and then a sample size calculation, all these things will matter a lot. So these are the same principles what we use in general research methodology when we are defining what is a population. So target population, then we have accessible population, and we have a sample. So I think this is clear. Yeah, I am told. Yes, sampling is the act of drawing a sample from a population so that sample is representative of this population. When studying the relationship between smoking and cancer, we cannot study the entire population because it's not feasible. It appears to be very costly. So we try to do this particular or test this research question probably in a smaller group and try to extrapolate these findings to a larger group. So this is what is meant by sampling and sample. So whatever hypothesis we are testing on a sample, we try to generalize it to the population, and this is what we expect out of our study most of the times. If you have to generalize these particular findings from your study to the population, then you need to have certain parameters where you have to draw an appropriate sample, which we will actually look in the further slides. So what is a sample? A representative group of subjects sampled from a population to make inferences on the whole population. So let us take an example. What is the proportion of men who are smoking in a town? And probably we will not be able to cover the whole population. We would like to cover this, we would like to address this research question by interviewing a random set of 1,000 men. So if you see that the smokers within the sample is 200, so proportion of smokers in this particular sample will become 20%. But this particular 20% what you are getting in your study probably doesn't reflect to that of what might be there in the actual population. So always this 20% comes with a rider of something called as a sample error. So that will be plus or minus of this particular 20%. So what is this precision? Precision refers to the magnitude of the standard error or the sample error of a measurement. That is, it says the width of the confidence interval. So 20 plus or minus what is usually our confidence interval what we tell, and wider the confidence interval, then lesser is the power of that particular study. So let us take one example. You can see in both these particular prevalence surveys of malaria, we get a prevalence of 10%. However, in one of them we have a confidence interval, 95% confidence interval of 5 to 18, and another one we have 8 to 12. Which of these do you think that is a better one? First or the second? The second one. Why? Why so? If we conduct this particular study, 95% of the times, the result will remain in this particular range of 8 to 12%, and it is a smaller confidence interval, so the study results will be more valid. Okay, in ORs, for that matter, any of the studies, this is one particular software which is open access software for calculation of sample size. I'm not going to the live version of this particular software, very easily available, OpenFP. You can choose the type of study design which you are using in your study, for that matter operational research or any other study, and calculate the sample size by inserting the appropriate values. Okay, so what is the HIV prevalence among TB patients in a particular site? So probably if we expect the population size of around, because we are looking at TB patients, so those form our population. So 1,000 new patients of TB in a year, and anticipated frequency or probably whatever the numbers what you are getting from earlier studies or from your pilot says that 70% of these people actually have HIV. So keep a precision. Most of the times we take it as 5%. So using this particular formula on OpenEpi, you will be able to calculate the sample size to achieve 95% confidence interval. 245 would be the sample size. So this is for the proportion study or the prevalence survey. Similarly, you have formula for calculating what needs to be the sample size in a cohort study. This is again by using OpenEpi. There is for RCTs, for observational studies, for RCTs, there are separate formula available in this OpenEpi software. You can use them. So we have used in most of our ORs, and I mean they are. It's very easy, open access. You can use them. This is one thing what you need to remember in any OR, for that matter any research. We try to calculate the sample size for probably one objective or probably the first objective. So we need to be very clear, calculate the sample size for the key objective first, and the best is calculate the sample size for all the objectives and take the largest sample size in your study. That would be always a better way to go. You have always a justification that you have done this. Even if you have a plan to include all the accessible population is geographically where you can go or temporally where you can involve them. Please calculate the sample size, because you will be able to get to know whether you have sufficient numbers, sufficient power in your study. So this is one exercise which you have to do, even if you tell that I am taking a census method of sampling and including everyone, all the accessible population in my geographical area, but still you see whether this particular sample size is enough to meet your requirements of the power of your study. Common mistake, we would like to see association of diabetes mellitus with outcomes among TB patients, but sample size we try to calculate for prevalence of diabetes mellitus. No, it cannot be done. So you need to adhere to the objective which you are looking for as a primary objective, calculate the sample size and then see for whether the sample size satisfy the criteria for all the other objectives which are there in your study. Yeah, I will not dwell much into this. Yes, all the traditional methods of non-probability sampling can be used, probability sampling can be used in operational researches. However, if there are any, you can say adjustments which need to be done to take care of the design effect, you have to appropriately use those design effect multipliers to take care of the sample size. So simple random sampling, very traditional method, very good method. Probably you need to have a sampling frame and you don't require any design effect. For all other methods under probability methods such as stratified, cluster, you would be having some design effect which would be required. But please calculate the sample size even though you are taking all the accessible or geographically accessible population. Yeah, probability and non-probability sampling methods. Yes, when non-probability sampling methods come handy, especially when you are doing some qualitative researches or mixed method researches where you don't have the sample size. For example, snowball sampling or even voluntary response sampling, but they have their own disadvantages. Whichever method of sampling you are using, when it comes to mixed methods, please clearly write mixed methods design will have quanti as well as quali. So for quantitative, what is the method of sampling, what is the sample size? For qualitative, what is the method of sampling and what is the expected sample size, probably till the data saturation is achieved. So these things need to be written clearly. I am not going into the study designs because of paucity of time. I have already told you saying that what are the possible study designs which can fit in any operational research. So this is about the study population. Study population, writing about study subject, study population or your sample is under the method section. You have to write time, place and person, whether you are looking at all or whether you are looking at some or a small part of it. Then if there is a sample, you need to write what is the sample size and what is the method of sampling. Then if it is all accessible population, then whether this particular whether this particular population is enough to meet your study requirements or give enough power to your study. So all these things look at under the component of study subjects or study population, and then sampling and sample size. Yes, that's it from my side in this particular thing. One more thing which I would like to touch upon. No, fine. Here we have different types of variables which are used in our quantitative methods. I am not going into this. This will be given to you. The presentation is there. You can use it. Yeah. This is one thing which I want to tell. There are two important variables when you are doing an operational research. One is dependent and one is independent variable. So if you take this as an example, risk factors for initial loss to follow-up among adult patients with drug-sensitive TB in Kerala. What is a dependent and what is an independent variable here? Or what is an outcome and what is a predictor variable? Quick, so if you are telling this, that is what I want out of this particular few slides which I have skipped. Loss to follow-up is the outcome what you are looking for, or that is a dependent variable. Okay, so risk factors, you have probably certain age groups, certain gender, one of the genders, or probably certain habits associated, or probably cost. All this will become independent factors, or they are the predictor variables. So this is probably a cross-sectional study which you are looking at, and you are assessing both at one point of time, okay, based on the records or based on a certain follow-up in a certain duration. So if that is the case, then it will become a cohort. So please look at this, and you should clearly spell out when you write your methodology what are the dependent variables and what are the independent variables, because this will give a clarity for the people who are there in SRB, who are there in ethics, who look at these particular protocols. When you write it as operational research, people think that it is something which is different. Okay, no, it's the routine research what we are doing probably in the programmatic context to improve the outcomes. So you may have to educate the people who are there in these particular boards, especially when you are writing these, and it's a structured way of writing. Next, this is the next important thing. This table needs to come in your methodology. I told an independent and a dependent variable, or predictor and also a predictor variable and the outcome variable. Now, when you mention your objectives, how are you going to capture the data for this particular variable needs to be written. So if the objective is determine the treatment outcome of MDR TB patients among the TUs of Kozhikode district in Kerala, so what are the data variables with possible values? So how are you going to assess the outcome? Those will tell what are the data variables. So probably cured, okay, transferred out, or failure, or completed treatment will all become your possible values for the treatment outcome which you are looking for. So from where are you going to get this particular data? Are you going to interview the patients? Are you going to interview the doctors, care providers, the health workers, or are you getting from the records? So that will tell you, the last part will tell you the location or the place or the site or probably the records or the persons from where you will be extracting or getting the data. So this is a very clear form of writing the sources of data, the data variable along with its possible values. Why possible values are required is when you are making your data documentation sheet or when you are entering your data, the data entry operator will also benefit from this because you will give the possible values and its codes. So this is a structure which will come under the methods section along with study population, sampling methods, sample size, and then what are the possible values for the data variables, and then the source of data. If it is a mixed method study, then this is one thing which you have to write under the mixed method section, quantitative part, qualitative part. Under the qualitative part, what are your objectives which would be under the qualitative part, and then what are the possible variables, okay, what are the sources of data, and what is the data which you will be getting. So here, explore factors influencing HIV testing of the spouse from patient, uninfected spouse and provider perspective. The variables would be questions basically from the interview guide. The data I have put up over there, and these will come from the transcripts, and then from where are you getting this particular data? Probably your key informant interviews or in-depth interviews or probably FGDs. So this is the way how you can present the requirements in case of the mixed methods study. So I have not gone into the types of variables, probably that the presentation will be shared, you can look at that, but this is what minimally we expect in any protocol when it comes to the operational research. And the same components of the protocol, whatever you have developed, will go as a method section in your manuscript also. So be aware, people who are reviewing these operational researchers do follow these particular guidelines, and when we as reviewers also, when we see the manuscripts which come to us for review, we will clearly make out, okay, this person is trained in operational research if we are looking at these particular things in the methodology, because these are structured things which are usually there in any OR paper, and we appreciate them. We usually don't have comments. We get to know, okay, this person has seen this, this is what is being followed, and that's it. So method section, when you write clearly your method section, half of your manuscript is actually done. Okay, so that's it from my side. Any doubts, queries I will take. I have to rush through this because we need to give you some time to work on one or two research questions. Yes, any doubts? Yes, madam. You can mention it in the title. Okay, you can mention in the study design also, but basic study design needs to be mentioned. People mention it in the title, it's okay, you can mention it. In the methods also, people usually write an operational research conducted with this particular study design in the programmatic context. People write. When there is a scope to write in verbose form, people write and it is accepted. It is not that, it's not wrong to write. But your core study design should be mentioned. Whether it is cross-sectional, whether it is cohort, whether it is case control, or if it is mixed methods, under quantitative, what is the study design? Under qualitative, what is the study design? And usually once you are doing it in a programmatic setting, people understand that it is an operational research. Anything you want to add? Any other questions? Yes, it can be purely qualitative. It can be, we have some of the researchers done on a pure qualitative basis. I think one, Rekha published it, no? Rekha was a co-mentee of our same batch. Dr. Rekha, she is working, I think, in somewhere down south in Kerala. Rekha Rachel Philip. So Alapi, yeah. She published one on palliative care in Malappuram district. So there were 2 parts called Conti. She published a separate paper, and following that Colli was published separately. It can be done. However, for Colli, it is always better to have a person who is very well trained in Colli as your mentor, probably, or a person who can support you, especially when it comes to culling out the data from the transcripts and coding and all those particular data analysis. That's very important. Because pure Colli, when you submit it to any journal, it will go to pure Colli researchers for review. If it comes to me for a review, I write saying that I am not a pure Colli researcher, so please, I have written that. So please, it's beyond my purview, because you need to, if it is mixed methods, yes, I do. Where? Because the Colli will be supplementing the Conti findings, or we are explaining something which we couldn't find in Conti through the Colli. So how are you framing a?
Fine. So research question for a qualitative study, in that case, we use some of the different terminologies, like to explore the factors associated with that, or to explore the facilitators and barriers to the implementation of this particular method and all, right? So in qualitative also, we have the component like PICOT, we have SPIDER. If you have heard the terminology, it is SPIDER, right? Where S stands for sample, PI stands for phenomenon of interest. So in what sample I am interested, what is my phenomena of interest, right? D is for design, like which qualitative design, whether am I using FGD or whether am I using in-depth interviews, right? So that comes in the research question about when it is related to qualitative, right? But per se, writing qualitative research question won't be separate. We usually write it like, say for example, if I want to find reasons for loss to follow-up, so that is a qualitative study, right? So how can we frame a research question? What are the reasons for loss to follow-up among MDR-TB patients registered in Kozhikode district in 2023, right? So all MDR-TB patients registered in 2023 would become my sample here. Instead of the word population, we use sample, because qualitative won't be on a larger scale. You have maximum, say for example, 20 interviews or 25 interviews or so on, right? And in that, objectives, as we had mentioned, to find out the proportion and all, here we don't have percentage and numbers, we try to explore the reasons, right? So we use the term explore or to find out or something like that. But to assess or to determine, the objectives when they start with the adjectives like to assess or to determine, that is usually quantitative component you are looking at. But when you are looking at qualitative, we find to explore, right? Or to find out something like that, to study. Okay, so that is a different terminology between quantitative and qualitative, right? So PICOT and SPIDER, you can remember these 2 acronyms. R stands for research type, huh? I forgot the R, last one, SPIDER. Yes, any other questions? Okay, so in the next 10 minutes, I would like to give you one example of a good OR project which was conducted in Kerala only. So we can take that example and then we'll give you the group work, right? Thank you. So let me give you an example of an operational research project which was conducted in 2014, but still it is of current relevance, right? So I thought, and since it's from Kerala, so I'm taking that example, right? So this was the operational research where the title of the project was, when it is published, when it was published, this was the title which was given. They know, they agree, but they don't do. The paradox of tuberculosis case notification by private practitioners in Alapi district, Kerala, India. Right? So what could be the population here? Yes, the The population becomes private practitioners of this Alpid district, right? And what is my outcome? What I want to see? Tuberculosis, related something to tuberculosis case notification, right? And this was published in PLOS One, and Sairu Philip madam was the first author, and she was also part of the sorted course, and it was her paper which was presented and got published in PLOS One journal, right? So now coming to when you have a research question and all frame in your mind, you give a brief background, right? And in this background, again, those three things we are going to remember. We'll focus on what are the program objectives, what are the constraints, and how I am trying to address those constraints, right? So the formerly known as RNTCP at that time in 2012. So the program was, there were 1/4 global incidence of TB in India, and if you see, it was notifiable disease in May 2012. So that was the program objective, that every TB case has to be notified. Now what could be the challenge? And for that they had operated online software, that is web-based system, Nikshay. We all have heard of this term now, right? So now what was the challenge? The constraint was that notification was there from government setup, but notification was less from private sector. So there came the constraint, or there came the problem, that there has been less notification from the private sector. So now what would be my OR, what would be my objective? To know the reasons. What is an issue in the private sector? Why they are not notifying TB cases, right? So with that, as I said, the problem, you have to have some facts and figures also with the problem. So there were around 200 clinics from private sector, which included hospital, laboratories and clinics from private sector. They were registered in Nikshay from Alpid district, all of them. But only 3 TB cases were notified in the Nikshay web portal from the private sector. So only 3 cases, right, which is very less as compared to look at the total TB prevalence or incidence, if you see. So maybe the private practitioners who are supposed to notify TB do not know, or they don't agree with the TB notification or Nikshay. This may be the broad research problem. So see the research questions now. Do private practitioners who manage TB in LP know about Nikshay? That was my first question. These are my objectives. What is the first objective? Whether they are knowing or not. Second is, if they are knowing, they agree with the Nikshay scope, right? And the third would be, even if they know, they agree, whether they are following that or not. So they are implementing that in practice or not. So these were the 3 main objectives of this particular study, right? So as Akshay sir was mentioning about this methodology, you need to mention these are the subheadings. We will share this PPT with you so that you can have a look also in detail. We mention about what type of study design it is, what is the setting, who are the participants, which variables, what were the source of your data, how did you do analysis and statistics, and what are the ethics approval. So these are the broad subheadings of any methodology section, not only in OR, but in general research also. When you go for a methodology section, it should be as detailed as possible, right? So study design, as we mentioned, usually there is a mixed method study nowadays which has been broadly accepted, and it answers why and how also at the end. So quantitative will only give you numbers, but it would not give you the reasons sometime, right? So again, this was a mixed method study where a quantitative component was cross-sectional thing, right? A survey was done among all the private practitioners, so that was a quantitative component, and a qualitative component were interviews were conducted among these private practitioners, right? And that was conducted in 13-14. Now study setting means they have mentioned about LP district and how many private practitioners are there and everything they had mentioned here. Study setting, where are you going to do the study, right? So if you are doing in your particular institute or in your hospital, please mention brief detail about your hospital, that where it is located, what is the specific characteristics of your hospital, like you cater around this district or nearby districts also you cater around. What is the study setting, where are you going to do the study? That has to be explained in this particular heading. Participants from the population, now we use the term what? Study participants, because we need to be more focused now amongst whom I am doing the study. So here quantitative, it was mentioned all private practitioners are allowed treating presumptive TB patients, which include MBBS, physicians, pediatricians, and pulmonologists. So all private practitioners were considered here. So now there is no issue of sample because we are taking everyone, right? And qualitative, here private practitioners and public health providers interested to share their views on TB notification were chosen purposively. So that was which sampling method? Purposive sampling method. Those who were ready to participate in the study amongst private practitioners as well as among public healthcare providers, right? We wanted both their angles to look upon it, right? To find out why they were not doing NICSHI notification, TB notification on NICSHI portal. So these were the variables. I'm not going to detail, but you need to mention about what variables you are collecting, how are you going to collect, right? They were Likert type questions from strongly agree to strongly disagree, right? So these were the quantitative tool. And qualitative, they had planned personal interviews, which were 10 to 20 minutes. A guide was developed, no recording. They did not allow that. Private practitioners felt that this is a notifiable disease. Some action may be taken by government. So they said that recording won't be possible. So we did not record the interviews, right? It was just notes were taken, right? Only field notes were taken. So the source of data becomes the questionnaire, that is for quantitative, and for qualitative it becomes interviews. Clear? And analysis and all, sample size was not calculated because all sample was taken, data was entered in this software, chi-square test, and simple statistics. It was not very hi-fi statistics was done. In operational research, usually your simple statistics would suffice. Okay? And qualitative, the field notes were transcribed and they were manually coded, and themes were generated, and like some themes would be clubbed together, and then basically we had some global theme and a thematic network analysis was done, right? This is again a qualitative thing, so those who have done some work in qualitative research would be aware of these terms. But don't worry, it is just like some categories you club together and put it into one broad category, as simple as that, right? I'll club together some of the categories and I'll put it at a broad theme. Okay? Like say for example, if there are issues related to software, कि कंप्यूटर में सॉफ्टवेयर का सर्वर डाउन होता है, इंटरनेट कनेक्टिविटी नहीं है, मेरे पास कोई स्टाफ नहीं है जो डेटा एंट्री कर पाए, then all these I can put together and label it as related to software. If I want to still give a broad, so software का problem है, इंटरनेट का problem है, कंप्यूटर नहीं है, right? So all this becomes logistics. That can be a broad theme. Are you getting it? This is how in qualitative we club together and we make a category, and that category again will be clubbed together to make a broad theme, right? So that is how qualitative data analysis was explained. This is about ethics approval. Of course, as I mentioned, you need to take an ethics approval. Now see the quantitative results. What were the results when this operational research was implemented, right? So response rate was 80%. So out of 200, all those private clinics and hospitals and doctors, 169 private practitioners participated. They agreed. They gave willingness to participate. So response rate was very high. And see this. How much of them were aware about it? That it is mandatory? 88%. They were aware that we need to do this TB notification, and it has become a mandatory business now. We have to do, every TB case has to be notified on NICSHI. That is, knowledge was there in 88%. And the small analysis which I said, only chi-square test was done, and if you see, general practitioners were significantly more likely to be aware about mandatory notification as compared to specialists. So this was one of the findings which was found out, that GPs were knowing more, maybe IMA was active or what were the reason. Now where can I get all these reasons? From the qualitative interviews. When I conduct interviews with them, I can have these findings at the back of my mind and I can frame my questions accordingly for the qualitative part. Okay, I'm not showing this tables and all. You have the access to that manuscript. I think it was shared in your group. So you can look at it, and these are some of the tables and all. And similarly in qualitative also, we found barriers to notification. Now main purpose was why they are not notifying. First objective was clear, that knowledge was there, yes or no? Yes, right? Attitude, everybody agreed? Yes. Now practice, what was the problem? Right? And for that we had to do a qualitative interviews, and we tried to find out what were the barriers to notification. So see, these were the main themes which we came up. There are some provider misconceptions regarding non-DOTS regime. They felt that if there is non-DOTS regime, there is no need to register on Nikshay. So that was, what is that? It was provider misconception. They had a belief that if I am non-DOTS regime, there is no need to register on Nikshay. They thought government is only looking for DOTS. So there lies the gap, right? So this is simple. So what is the solution now? Recommendation, operational research will give immediately based on the problem. Proper educating, proper awareness, proper training, simple, right? And clarity that even non-DOTS regime has to be registered on Nikshay. Then there were some things regarding patient confidentiality, stigma and discrimination, right? So again, that part we need to take care of, right? That we are not going to disclose to anyone, to their relatives or anyone that this is a TB patient. It is just a notification with the notifiable disease means government would get the data how many patients are there. So there is nothing to do with the name of the patient or anything. We are not going to disclose to everyone, right? And lack of cohesion and coordination between public and private sector. So that was again one of the challenge which was found out. Okay, public sector and private sector mein there is not much coordination. Okay, they felt that they are going to take our patients. हमारा जो consultation का money मिल रहा है वो नहीं मिलेगा, drugs के लिए, whatever things. These were some of the minor things which were there between miscommunication between public healthcare providers, that is government doctors versus private practitioners, right? So this is how we got themes based on qualitative interviews, okay? And this kind of diagram. So if you see, provider misconception was one category, lack of cohesion was second, and patient confidentiality, stigma and discrimination was the third. So main theme became what? Barriers. And these three became some of the categories, and these are the codes in each categories. Right? And how do you get these codes, categories and themes? From the verbatim. What we have said in the interviews, from that verbatim, we can get it, all these codes. And then they clubbed together to form a broad category. Right? So see, these are some of the codes. Like all my cases on DOTS are reported. Oh, I did not know that those on other regime need to be reported to a government. Right? So from this we picked up that non-DOTS regime, they are not reported on Nikshay. Right? This is one example. There are many other, but I'm not going to detail due to shortage of time. We want you also to do some hands-on exercise. So this way there are some of the codes. Right? Her father begged not to send his daughter to the government or report her diagnosis to anyone. So this became issue related to stigma and discrimination. Right? Patient's perspective. उनको ऐसा है कि किसी को बताना नहीं है TB हुआ है. So we did not register on the Nikshay or on the app. Right? Okay. Approach to private by government is very bad. They do not give us respect. So private practitioner को ऐसा लग रहा है. I don't like the stepmotherly attitude of government to the private. उनको ऐसा लग रहा है कि private के साथ ऐसा कर रहे हैं हम लोगों के साथ. So these are some of the things which would not come up in your quantitative thing, right? So qualitative flavor, if you add it to your operational research, it would answer why and how. Why it is not working or how it can be improved upon. So that two answers can be given up by the qualitative flavor to your research. Okay. So the interpretation was these three last line, and I would stop here. Majority of private practitioners in LP Kerala know about Nikshay. Majority of private practitioners agree with the Nikshay. But several barriers prevent them to notify TB, including misconception, stigma, discrimination, and some lack of coordination between public and private health sector. So this was the theme, or this was the outcome of the paper, right? And based on this, these are the strength of the study, that all practitioners were included. So there was no sample size. We included the comprehensive sample of all. Weakness, it was a limited geographical area. We did only in one district, right? That is fine. And how could this operational research impact on RNTCP Nikshay? What program would get? We would get the insights that how can we improve in Nikshay, or what are the strategies we can hold on. So these was the entire suggestions which were given by, if you remember, interviews were conducted both with private as well as public health providers. Right? Means government mein ko bhi bola ki how can we improve this notification. Right? So these are some of the solutions, like notification process ke liye they should contain relevant and minimum personal information because they had risk of stigma and discrimination. So these are some of the suggestions which were given based on the reasons. Right? Then rewarded provider misconception of non-DOTs. What can we do? Training to all the doctors can be given. That non-DOTs also needs to be notified. So simple solutions would be there, right? Related to patient confidentiality and stigma. So as I said, confidence building has to be done. Confidentiality will be maintained of that data. That assurance needs to be given to the patient and the providers. Clear? So this is how a good OR can finally end up with giving proper suggestions to the RNTCP program, now known as NTEP. And based on that, sometimes policy level changes are made. But after this, if you see, IMAs and all had also become very active, and there were CMEs and all were conducted based on that, and NICSHA notification. And now I think it would be the, not 3, right? Almost all have started doing TB case notification, right? So that way you improve upon or you change upon your policy or practice level changes can be made based on such operational research, right? So a good OR ends in such a way that you give some suggestions, some recommendations to whom? To the program level, right? Those who are implementing the national program, to them you give proper suggestions based on your interpretation of your operational research, right? So I'll end here. We have exactly half an hour now before lunch. So we can have 15 minutes for group work and 15 minutes for discussion on whatever group you have worked upon, right? So you have been divided into groups. So if you can see here, there have been numbers placed. So if you can sit there quickly, this is number 5 sitting here, I think. Number 3 is there. Number 1 is there. No, in this way I'm not put it. So you have some of the questions related to TB diagnosis. Select any one and try to make a research question. The task is clear. There are examples given related to TB diagnosis, select any one and frame a research question, operational research question. And remember the components, right? Be as specific as possible, right? And focused on that particular research question. Group 2. Yes, so you have TB notification, number 2, theme number 2, TB notification. One example you have already taken related to TB notification. Think of some other. Examples are there with you in the slides. Group 3. Group 3, all of you are in group 3, so you will look for TB treatment adherence. Okay. Group 4, TB supervision and monitoring. Right? TB supervision and monitoring. Group 4, you can sit together, all group 4 members. You have to come up as a group one research question. Right? Group 5, number 5, you all have? Yeah, so you have TB HIV. TB HIV and TB diabetes, both may say whichever you find it. TB HIV, TB diabetes. And last, group 6, drug resistant TB. Group 6, DRTB. So you have exact 15 minutes and then we will have presentation from each group. 2-3 minutes for each group. Is the task clear? Yes.
Every group will be given only 3 minutes for presentation. After that, we'll ring the bell. Once we ring the bell, then the next group can present.
Research question. Only the research group, yes. Including discussion.
Good afternoon. Myself, my name is Dr. Iman. I'm coming from Calicut Medical College. I'm a PG student. So the topic that was given was the treatment adherence of TB, and the research question is, does direct benefit transfer really help the TB patients registered during 2023 to 2024 in Calicut district? Was the question. So the objectives is to estimate the proportion of TB patients receiving direct benefit transfer. That is the first objective. And the second objective is to explore the utilization pattern of the direct benefit transfer among the TB patients. The qualitative component.
No, I am just asking in what form can it be better presented? Picot, finer, or spider? Picot, correct? You would like to present it in a Picot format. So, who are the population? Who is the population over here?
Patients.
Okay, tuberculosis, patients with tuberculosis registered in 2023, registered during 2023 in Calicut district of Kerala. Okay, 1. So this is the population. Is there any intervention? No intervention. Is there any comparison group? No. And outcome? What are you going to assess in the outcome? The utilization pattern of this, is it reflected if that is the case? Something that should be, if you are planning to look at the utilization pattern of this DBT, then it should be reflected in your research question, correct?
What could be the route? What benefit you actually because of DBT?
What the government claims from DBT?
Treatment adherence.
Huh?
The treatment adherence and
Okay.
nutrition.
Okay, the treatment adherence, probably yes. So treatment adherence leads to better success rates, 1. Second thing is, okay, it can be, basically DBT of 500 is targeted towards improving the nutrition or to purchase nutrition amongst TB patients. So what can be your outcomes now? I've given all the clues. So which of these can be the outcomes when you are assessing something related to DBT? Yes, anyone else? Okay, Okay. So assessment of weight gain. Okay. Anything else? Adherence.
No, completion of treatment and weight gain.
Okay. So do you expect that can you put all these three into one particular thing? Probably treatment success rates. Okay. So does
DBT really help?
now you tell. Now you rephrase your research question.
Does direct benefit transfer really help in the treatment success of TB patients registered during 2023 in Calicut district?
Okay. Does the direct benefit transfer by the Government of India to tuberculosis patients in Calicut district of Kerala registered during 2023 benefit in improving the treatment success rates? Or you can put it in a other way, among the patients registered, among tuberculosis patients registered in Calicut district of Kerala during 2023, does direct benefit transfer increase the treatment success rates? Okay. Okay, fine. If this is the research question, now try to tell what are your objectives. So research question, as Dr. Kedar told, it is another form of putting your aim. Okay, so the ultimate thing what you should achieve out of your study. So what can be your objectives? First one you have already told.
Proportion of
TB. To estimate the number and proportion, or to determine the number and proportion who received the direct benefit transfer timely, or you have to put who received the first installment of direct benefit transfer within 1 month of registering for treatment. This you have to operationally define. What is timeliness of DBT? There is a definition for that probably in the program. So within 15 days or 1 month or whatever it is. So you need to write that. So that will give you. No, I'll come to that next. Okay. So that is the first thing. Second thing is number and proportion of patients who have received all the installments of direct benefit transfer. Second thing. Third thing is to what?
Explore the utilization pattern.
Yeah, to determine the number and proportion of patients who have completed their treatment or assigned treatment success amongst these particular patients. Fourth one, to look for the factors or to determine the factors associated with treatment success rates. Okay, so that will give you all the factors along with probably DBT also. Yes. Treatment, treatment success in TB program is defined. You can use the same definition. So successful outcomes is completed treatment or declared cure. So that you can use it for the definition, and program has the guidelines for this. So from where are you going to get this particular data? Sources of data. Okay, through Nikshay portal, through patient treatment cards, to TU registers, all these are your data sources. If you want to add a component of qualitative into this, so you can always add that what is the utilization pattern of this one. However, word of caution over here, don't use qualitative for the sake of using qualitative. If you are able to get these answers through the Conti, where you are putting this particular question, giving them options, you can as well as do that. Okay, a telephonic interview of the patient will supplement your data what you have extracted from the records. You need not do a qualitative at all. Clear? Those are my thoughts. Okay. Anything else?
And
I think this OR has already been done also, so you can have a look at literature search also, so that you can refine more, right, as sir mentioned. So now you refined and you rephrased, you found population is also there, intervention is also there here. What is the intervention here? What is the intervention here?
Something which is coming.
Yes, speak it aloud. DBT is the intervention here. Although we are not doing it, intervention doesn't mean that we only have to do, it is already there in the system. So the intervention is DBT. Population is this, as sir mentioned, TB patients registered in 2023 in particular district, Kerala. Right? There is no comparison group, and outcome would be success rate. Right? There is no such group who would not be getting DBT, because all registered would be getting DBT. Okay, so if you have that group, then you can have the compare the treatment success rate in both the groups. Yes, one receiving DBT and one not receiving DBT. Fine. Okay, good. X. So claps, kudos to this group. Very nice startup. Who wants to go next? Next. Quickly. Which group? Yes, fine.
Myself, Dr. Arya from Srinaran Institute, PG student. So our topic was drug-resistant TB. So the question is, what are the challenges and outcome of shorter drug-resistant TB regimens among the adult TB patients reported in the Nikshay in the Kozhikode district from April 2022 to December 2023. December 2024, sorry. Adult TB patients who has registered in the Nikshay in Kozhikode, Calicut district.
Adult drug-resistant TB patients.
Yeah.
So all these things need to be specifically written. Adult drug-resistant TB patients registered from which quarter to which quarter, or if it is the whole year, during all 4 quarters of 2023. So what are you going to do next? You would like to, what is your research question? Continue this.
Sir, again.
Yes.
Intervention is challenges and outcomes of shorter drug-resistant TB regimens.
So intervention is shorter.
Shorter drug-resistant regimens.
Shorter regime for
MDR.
So shorter regimen is already a part of the program. So people are being given that there are some inclusion criteria for that. So only those patients will be getting shorter regimens. So you want to see what are the treatment outcomes in this particular set of patients who are receiving the shorter regimens. Okay, so that is one. Second thing is challenges in delivery of the shorter regimen. Correct? So this is the second. So you can put as 2 research questions, or you can put as 1 research question, one after the other, and challenges in delivery of this particular, this one. Agreed. Very well. So what are your objectives?
You just convert these into statement and make some measurable thing.
First objective, outcomes. What are the outcomes?
Okay, to estimate or to determine the number and proportion of patients who have had successful treatment outcomes following the shorter drug regimen for treatment of DRTB. 1. Second is, once you write successful, you will also get not successful or unsuccessful treatment outcomes. So that also can be your part of the
what are the failures
first
and
or
success
second objective, you can put it. Then
the failure rate and success rate also.
Yeah, so all those will come. So success rate is the first one, treatment success, and then you will get failures or whatever, unsuccessful treatment outcomes.
And adherence or compliance.
So if you want to, if you want to see for the adherence and compliance, you can put that as an objective, and last objective would be to identify the challenges in drug delivery or providing the patients with this particular treatment. So who are you actually looking for? What are your data sources? Quick. So for your first objective, how are you going to look?
Nikshay portals.
Okay, you are going to look at Nikshay portal, one. Second thing is, you should not entirely depend on Nikshay portal.
And
okay, you have to look at TB treatment, DRTB treatment cards maintained at the DRTB centers and the DRTB registers. So all these three will be your data sources. And second thing is, you want to look for adherence or compliance. So how are you going to look at that?
By assessing the follow-ups.
Pardon?
The success rate.
If you have to look at the adherence or compliance,
we'll have an operational definition for that.
Correct. But already if you are looking at the, if you are taking the data from TB treatment cards, the patients should have already finished their treatment. If you have to look at adherence, if you have to look at
the
compliance,
duration of treatment.
If you have to look at adherence,
so the duration, follow. So the duration is short, the people, they will be more happy, like they won't be having any difficulty to continue the treatment successfully. So through regular follow-up, we can assess that. But we can get an idea, sir, for like loss of follow-up. Any details? Loss to follow-up.
verify it when the patient is actually taking the treatment, probably at the end of 2 months or at the end of 4 months or at the end of 6 months. So that is one way. At that particular time, your study design will not be observational, it will not be cross-sectional, it will be cohort. That means you are following up these particular patients. So you can actually, if you want to look for adherence, you can enroll a cohort, okay. All the people who are started on treatment between this particular period to this particular time.
And again follow.
Yeah, you have to follow up till they finish their treatment. You will be able to look at their adherence also and issues related to adherence. One thing. So that will take care of 1, 2, 3 objectives. Now fourth one, you told about challenges. So what is the population? Who are the people whom you want to look for? If you have to assess or if you have to explore, I don't want to say assess, explore the challenges.
Read again the question so it will be more clear to you only.
No,
to explore the challenges, read that objective.
To explore the challenges
in providing
the
shorter
drug resistant regimen treatment.
So what is your population? Challenges किस में देखना है? Who is giving? Yes.
Program through the
Doctors and healthcare providers. Providers perspective. Providers perspective. And healthcare providers for?
This particular, okay.
So that is why you have to write it as detailed as possible. Okay. So probably you may have the SRB and ethics should come back to you saying
objectives.
Facilitators.
So for collecting data from the patients or from the healthcare provider, you can have
Interviews.
you can have key information interviews, you can have FTDs, that is depending upon the number, how many you want to capture. FTDs among patients get difficult because getting them at one particular place and issues, confidentiality, stigma, all this will become an issue. But among healthcare providers, yes, you can have it. That is a positive.
Okay, so excellent. Group 6, good question, right? Anybody else wants to add anything?
We take up one more research question. Anyone ready?
Anyone is ready with the research? Yes.
Good afternoon to all. Myself Dr. Enju Raju from Government Medical College, Calicut. Our topic was TB supervision and monitoring. We are planning to conduct the study in a mixed method manner. So our research question is, what is the proportion of TB patients getting anti-TB drugs other than FDC among patients admitted in Medical College wards of Kozhikode district, and reason for prescribing private anti-TB drugs by doctors during the year of 2023. And
Research question.
Sir, TB patients receiving anti-TB drugs or other FDCs?
No, your population amongst whom you are doing the study. You said no, registered during that has to be the entire population.
The patients, TB patients admitted in Medical College wards during the year of 2023.
So all patients who are admitted in TB ward in your medical college during the entire year 2023. So they have already admitted and they would be at home, right?
Yes.
So you have to think of your source of data accordingly.
Yes.
Okay. Then that is your population. Is there any intervention?
Intervention?
No. Okay. Any outcome? What is an outcome?
Sir, to estimate the proportion of TB patients getting the anti-tubercular drugs other than FDC.
Okay, so other than FDC, what is the number or the proportion of TB patients who receive drugs other than FDC that you want to find out, right? So there is only two components, I think. It is which kind of descriptive question? Yes, they have only two things. One is population and another is outcome. Population is all TB patients admitted in particular medical college in the ward during a particular year, 2023. So all TB patients would be your population. And outcome is non-FDC regime,
yes.
Right? And you mean non-FDC regime outside, means from the private, how many have taken, or you mean to say like that?
In the medical college itself, any doctors are prescribing any other drugs than the FDC.
Okay, other than FDC, if any, how many have been received? Okay, so what would be your source of data now?
So medical records library in TB, all the patients admitted in the 2023, we will get the data from medical records library. We will collect the case sheets.
You will get the case papers from that?
Yes.
Okay, and then how will you look at the outcome variable?
Looking at the treatment part, we can see the names of the drugs. Yeah.
Okay, otherwise they would be writing 3 FDC and 4 FDC, you mean like that? And if it is not written, then it is mentioned that they have been taken other than FDC regime or outside. Any other way of getting it, the data? Any other source of data? Anybody else? Yes, so one is NICSHI data also would tell you if they are registered in NICSHI, which regime they are on, and every detail has been given. So if they are non-FDC regime, they have to again notified in NICSHI. You can get it from NICSHI also. This patient has received non-FDC regime or not. Okay. Anything else? What you want to find out? Okay, once we got this, then what else? So don't you think operationally you would be more interested in why non-FDC regime was?
Sir, the second part is
that. Okay, please continue.
Second object is to explore the reason for prescribing this drugs, private drugs by the doctors.
So who would be your population here?
The doctors in the medical college.
Yeah, doctors who are there in the medical college.
And in the year 2023 or
Yes. Anybody else who would like to interview apart from doctors?
pharmacist.
Any other person who you would like to? Yes. Madam said DTOs and all. Right? So they would tell you whether there was drug shortage or what were the issues related to drug. So any administrator, I mean to say. So here administrator would be maybe DTOs. So you can have, these are known as key informant interviews. We don't say in-depth interviews. We say key informant interview because these are some of the person who are known as key personnel, right? Who are stakeholders, right? Who have a major role play in the TB program, right? So maybe STOs or DTOs, you can have interviews with them also, and we can find out the reasons, like why a non-FDC regime was given, right? What were the reasons? Logistic issue tha, ya what are the issues? So that all can come up in the qualitative component. Good. Anything? Okay.
All the research questions what you are writing, especially when it comes to cross-sectional studies. Cross-sectional, I am telling descriptive studies, need not have PICOT format as he has already told in the morning. So it's just reiteration. So you have only population and outcome many a times. You don't have the other things. Usually PICOT is for analytical study, whether it is cross-sectional analytical or whether it is the next set of studies which follow cross-sectional, say case control cohort or RCTs. But it is a standard protocol to use this particular format to frame a research question. Okay, so as postgraduates, as you can say young researcher, you need to keep this in mind. Okay. Fine. Should we break? Yeah. They have not finished? Okay.
Yeah, they can have one more group.
We can have one more research question and then we'll wind up.
Yes. Oh, you want to try. Group 1 is now last.
Sir, I am Dr. Abarna, currently working as assistant professor in PK Das Medical College. So the theme was TB diagnosis and we have selected newer digital technologies. So the question we framed is, in improving the latent TB case detection among apparently healthy adults aged more than 30 years, how cost effective is applying artificial intelligence over the present IGRA technique in a tertiary care center of Central Kerala? It is basically an economic evaluation, cost effectiveness, between using artificial intelligence, and the outcome is to improve the existing latent TB detection by IGRA technique in apparently healthy adults who attend the OP, general medicine OP of a tertiary care center. Patients attending the general medicine OP and more than 30 years, apparently healthy, means not having any active TB symptoms. Yes. Yeah, when they are waiting in the OP, is there any artificial intelligence technique we can apply so that more case detection happens when compared to the IGRA, because which requires a little more resource for getting the blood, all those techniques. So is there, can we compare it, how much effective is new thing? No. So we have to develop, yes.
Dr. Akshay sir mentioned about 3 things, right? Which were those? One is
knowledge, lack of
knowledge,
lack
of tool, or inefficient use of tool, right? Here you can also say inefficient use of tool also, maybe IGRA. So your intervention would be new AI tool, whatever you design, that would be your intervention. Comparison would be
the present IGRA technique.
IGRA technique would be your comparison. Population would be, as you mentioned, right? Healthy patients coming to medicine OPD, right? And what is your outcome?
outcome is by this we can get more number of, if we can get more number of latent TB detection, we can start giving TB preventive therapy so that transmission can be prevented when they become active.
You are looking at sensitivity and specificity of a new
Yes.
tool versus an existing tool. Existing tool is a gold standard probably for picking up latent TB. So you are using AI technique to pick up latent TB. So you are considering this versus that. So you are looking at sensitivity and specificity, and probably, I mean, also
An
the cost
economic,
effectiveness, how better it is when compared to the this one. So you need to have an AI tool for that. What, how you can pick up the infection. So probably a breath analyzer or something.
So can we put an objective first as to develop a tool as an objective in this?
No, you can put it up. You can put it up, but if you ask me, development is basic science research,
Okay.
and doesn't qualify under the operational research. So it's better that you can develop the tool, you can publish it separately, and then development of a tool, and then you can see whether this particular tool is cost effective. But when you are publishing about the tool, you tend to do the sensitivity specificity analysis there itself. Yeah, yeah, please. Sir, yeah.
Actually, I heard so many things about these kinds of approaches, especially from developed world. Even you can diagnose a tuberculosis by how you cough, from the sound of the coughing, maybe X-ray, and so many things. Because a physician may not notice something in an X-ray, but an AI tool can notice something, a pattern. So you can, it is just like a black box. How the AI is working, we do not exactly know, but it is just like what your brain working. It is artificial neural network kind of thing. So these kinds of tools may be available already. You need not develop that. It may be available because even one of the research group from Singapore University approached me, that they asked me whether you have got some connection with some people treating tuberculosis in your state or something like that. The problem that they are facing, they don't have patients. They have got the artificial tools and all other things with them. Money is there with them. But the problem is they don't have patients. But we have patients, but we don't have these tools with us. So you can go and search it out, and you can find some groups. You need not develop, because development is highly, it is actually a costly business, especially these AI tools and all. If you are able to identify something, and you can use that, maybe you can go for a literature search, even you can go for a systematic review kind of things on what are the AI tools available, and you can approach them, and you can have an operational research based on that. That is what I think.
Thank you, sir.
Thank you, sir. Thanks for your insights about that. Okay, well developed this one. So what would be your actually data sources?
So one will be the current latent TB detection rate from the...
So data sources will be your patients, right? So the apparently healthy individuals who are visiting
the general medicine OP, baseline data will be there.
Yeah. So amongst them you are going to do latent, amongst them you are going to do IGRA, as well as you are going to do this
New
particular
tool,
thing. So
AI tool.
That is how, because you think that IGRA is the gold standard for identifying latent TB infection. So you are comparing the other one with this. So it is among the same set of population you will be doing both. Probably you will be applying the AI tool first and then giving them a IGRA. Any other comments, queries? Yes, thank you. That was a well drafted question. So this is pure operational research where the findings of this can be utilized at the local level. Okay, if this is being scaled up or if it is being done multi-centric, and probably the program manager in Calicut district to take it up, it can become implementation research. And if this comes out as a policy at the national level by larger multi-centric studies, then health systems research. So take this as an example and write in your paper if this question comes. And if I happen to be the examiner, then I see only that. Because people who have worked in certain fields, they know what is expected out of a particular answer. And if they are there, they search for those keywords. None of the examiners will go through each and every line. Okay, first my thing is I search for the keywords. If they are there, next step. Otherwise, go to the next. So that is what is important. When you are writing an answer also, you need to know how to draft and how to write. Probably that is not within the scope of this, but I thought I should tell. If I find an opportunity, I will tell. Okay, thank you very much for coming up with research questions at such a short time. Probably we have done the maximum out of whatever time we have got. That's it from my side.
So as we mentioned, you all came up with very good questions. You all can continue to work also if you wish to in future, and you can go up with a proposal if you wish to in your particular institution. So I would advise that once you dip into it, then slowly, steadily, you will definitely dive in and you will get good results. So I would make sure that at least give a small try. Don't think that, okay, it would be a very good research project or something. It's okay if it is minor level thing, but some operational change at institution level, if your project can bring up, we would be more than happy, right? So that at least we are just going the seeds today, but maybe after years we may meet somewhere and you may tell us that you are enjoying the fruits of your project, right? So thank you so much for the entire day workshop, and we thank the organizers for giving us the opportunity.
And if you want any sort of help, mentoring, we are open for it. Our email IDs are there. You can write back to us. But one word of caution is that you need to give your 100%. At that time, mentor will give 101%. If you give 1% and write a crap protocol, mentor should not spend his time in correcting is, was, that, this. Okay, if there should be a technical input from a mentor, then you should give your 100%. Please have a local mentor, your senior, your guide, whoever it is, and let us, everyone needs to be on a same page. You build your team right from the concept note when you write, because that is the team who will be working, which will be working on this particular protocol from the time of conception till the time of publication. So that is how OR teams are built. If you see, most of the OR papers have 6 authors, 8 authors, 10 authors, 20 authors. There are OR papers with 50 odd authors also. Okay, so you have to build that particular team, and you have to follow these particular principles when you are writing a protocol, and then involve us. Yes, we will be happy to contribute. That is not an issue at all.
Thank you so much, sir, for that groundbreaking session.
Now I call upon Dr. Nandini Gopala Menon, Associate Professor of the Department of Community Medicine, MES Medical College, to present the token of gratitude to Dr. Akshaya KM.
Next, I call upon Dr. Anish T.S., Additional Professor of Government Medical College, Manjeri, to present token of gratitude to Dr. Kedar Mehta.
Thank you, Madam and Sir. On behalf of the organizing committee, the department and the college, I thank our esteemed resource persons, Dr. Akshaya, HOD, Professor and HOD of Ephacon Medical College, and Dr. Kedar Mehta. He has traveled all the way from Gujarat. He is Associate Professor in Vadodara Medical College. So both of them have given their vast experience while taking. That was very obvious, I'm sure about that. So they have enriched us with the knowledge and experience. So on behalf of all of us here, sirs, we thank you so much for your valuable time. So I hope this session will be beneficial to many of us, so that in future we'll be taking up this research and our daily work. Thank you so much.
What an insightful morning we've had. We've been privileged to hear from some of the finest minds in our field, and I'm sure we're all leaving this session with new perspectives and ideas. As we move forward with our agenda, it's now time for a well-deserved break. We have prepared a delightful lunch for all of you to enjoy.
Yeah, welcome. Please come.
for the faculties is arranged in the PG seminar hall, and for the others it is arranged in the practical research lab. So please proceed to the to have the lunch, and the time is until 2:15 so that we can reconvene with our sessions of oral and poster presentation.
So we have to slowly hurry up, please.
It's a pleasure to invite you to have a tour of our Department of Community Medicine at 7th floor. We also like to tell you that we have arranged a photo booth for doctors to take selfies as well. Thank you.
Please don't forget to do the afternoon sign for the registration. It is in the 7th floor.
icon and never miss an update from Strings Affair.
Hi, I took more than 300 interviews when I worked for Facebook. 80% of people I interviewed for problem solving.
Good afternoon, everyone. I am Dr. Quinsley Pereira, and I will be presenting my paper titled Assessment of Attrition in the Tuberculosis Diagnostic Cascade in Mumbai City by Secondary Data Analysis of Nikshay Patient Lab Registers. So, as we know, TB is the world's top infectious killer, and in 2021, it was estimated globally that around 10.6 million patients, that is around 134 cases per 1 lakh population, fell ill with TB. Actual TB incidence to assess TB India's TB cascade of care, recommended that increasing case detection is critical. As per the NTP, the newer integrated integrated diagnostic algorithm for drug-resistant TB also provides opportunity for upfront NAT testing and universal drug susceptibility testing. This study aims at assessing the proportion of dropouts from that same diagnostic cascade in Mumbai city. Rationale: the state of Maharashtra has a case prevalence of TB of 119 per 1 lakh population, which as we just saw is more than the global estimate. And the CBNAT prevalence to notification ratio is 1.65, which is lowest in the entire country. This, delayed diagnosis remains an overwhelming challenge. And in a study conducted in Mumbai, a delay in the diagnosis and treatment initiation of 21.7 days was reported. Given the load of drug-resistant TB that Mumbai city already bears, along with that the other problems of overcrowding, housing problems and malnutrition, in all this scenario, if there is not proper following of the TB diagnostic cascade, then it will lead to wastage of resources. The Mumbai District TB Control Society is a body under MCGM, that is Municipal Corporation of Greater Mumbai, that implements NTEP in Mumbai city. And there are 24 wards in the municipal corporation. So there is 24 wards that are treated as 24 districts under NTEP. So the aim of my study is to assess the attrition in the tuberculosis diagnostic secondary data analysis of Nikshay patient lab registers. Objectives are to ascertain the proportion of dropout at various stages of the diagnostic cascade, to identify the point of maximum attrition in the TB diagnostic cascade, and finally to compare the attrition in the 24 districts. Methodology: all the new cases that were reported in the Nikshay portal in 2023 were taken for the study, and the data was analyzed by MS Excel. So what we are looking at here is a part of the integrated diagnostic cascade for drug-resistant TB as given in the Programmatic Management of Drug-Resistant TB, that is PMDT guidelines. As we can see, the supervisions are supposed to undergo upfront NAT, but we can see that out of 47,365 patients, 35,655 went for NAT. So here we see a dropout of 25%. After NAT is done, they are supposed to undergo line probe acid liquid culture and drug sensitivity testing. But before line probe assay, a smear test is done, and if it is smear positive, direct LPA can be done. But if the smear is negative, then the sample is taken up for culture, and according to the culture reports, if the culture is positive, then again LPA is done. That is called as indirect LPA. So at LPA level, out of 35,655 patients, 4,354 were reported rifampicin resistance detected arm. I will be discussing in 2 arms, out of which only 2,355 underwent LPA, giving a dropout of 46%. So now this 46% includes patients in whom the culture was positive. Even then they couldn't, if isoniazid acid resistance is not detected, those patients will be out of the cascade, as now they will be drug sensitive. So detected out of 8,229, 633 cases were such in which H resistance was detected. Now they are supposed to undergo second line and drug, liquid culture and drug sensitivity test. So a dropout of 11% was noted at second line, 26% at liquid culture, and 44% at the drug susceptibility testing. This was about the proportions dropping out at test per ill. So as attrition shows an increasing trend from first line LPA to DST in the detected arm, but in the not detected arm, initially it shows a dip and then again it shows a similar trend. Now this may be because the number of patients, the number of cases only decreases after the H status, isoniazid status in the not detected arm. As the number decreases, the chances of dropout may also decrease. That can be one reason. So these are my references. Thank you. Yes, hello sir.
How will you interpret based on the result? You gave me a lot of areas.
Yes.
So how will you interpret from that?
So as the points of attrition, the reasons for that is another study that is being undertaken. But as far as how much I could understand, the reasons can be, first is the patients who are clinically diagnosed as TB, they are not guided towards maybe molecular confirmation. Other than that, there are a lot of technical problems at the Nikshay app level that the ground staff is reporting. So such problems can be targeted.
And my second doubt was, did you arrange your data based on areas? You put it in different areas.
Yes.
But did
districts.
you arrange in form of South Bombay, Central, or any of that aspect?
No, that I did not do.
That interpretation.
I couldn't do that.
Sure. Thank you.
Thank you.
Yeah, Dr. Quinsley.
Good afternoon, sir.
Good afternoon. A nice presentation. Especially that introduction part was very nice. You just made your point very clearly, especially what objective you had. But a major issue that has happened is your methodology part. You just hardly spoke a sentence about the methodology, where we people are very much interested. How you conducted the study, how many people were involved, what kind of data you had, and what are the variables in those data. And all these things are important in a scientific presentation. So if you are going to present maybe in the front of for administrators, sometimes they may not be interested in the methodology. But when you are presenting a data before a scientific community, you have to give the methods maybe having more important. The most important part is the method. Because your method is good, your results are valid. If your methods are not good, your results are invalid. So that kind of an issue is there with your presentation. So I think next when you present, you have to give more importance for your methodology. And one of your chart, especially that component bar chart, what was the y-axis? Is it percentage? 1.5, 1.2, something like that?
No, sir. These are the stacked percentages.
Yeah.
But the y-axis has been some mislabeled, I guess.
Yeah.
Yes,
That I didn't get what it means.
These are the stacked percentages.
Okay.
I did not take absolute numbers because population of each district varies.
Okay. Just Saras mentioned, if you have given a geospatial data, it would have been more meaningful that some part of the city may be having high attrition rate and some part, because we are not able to witness what Mumbai is based on this particular data. If you can bring that kind of an aspect, I think that was good. So those are the things from my part. Thank you. It's a nice presentation. You made your case well. Thank you.
It was a very relevant. Given some training regarding the notification, because still
you're assuming all these things, because I think that part has not come in your
that study is going on, but this is all I'm saying on the basis of ground, whatever
you have seen at the
yes.
ground level.
I was also posted in the district TB office under my DRP, so I have worked in
Did you take ethics committee permission for the study?
No, ma'am. As this is secondary data analysis, I will be applying for the exemption.
Yeah, you still have to apply for the. Okay.
Thank you so much.
Cervical cancer is the fourth most common cause of a disease among women. It causes 6.5 lakh new. Third strategy was a review of published literature on the burden of cervical cancer, the available vaccines, the policy decisions on different platforms. A search on studies available on PubMed and Google Scholar was conducted. Studies on attitudes towards HPV vaccines in India published within the last 15 years was included. The willingness to cost with HPV vaccination was a higher awareness of the disease, health worker recommendation, a decrease in price, as well as a fear of cancer. There is a gap in India's HPV vaccine policy, which also be noted that even also have gaps related.
Yeah, Dr. Levin.
Yes.
As Madam has mentioned,
17 references. In your last bibliography references, there are 17.
Yes.
whenever you, and as I was going through, hardly 4 or 5 were on
Good afternoon, everyone. Today, my topic for presentation is knowledge, attitude, and practice. Knowledge on symptom and transmission of TB with poor practice among the general population and population. Now, coming to materials and method, my study design is cross-sectional study design, and we are conducting it in rural practice area under the tertiary care center. And our study population is adult population that is residing in the area for more than 6 months, and we are excluding the people who are working in healthcare sectors. And by using the equation n equal to z alpha square pq by d square, sample size was calculated based on the study done in Tamil Nadu, taking prevalence value as 10.6, and the calculated required sample size was 145, and we have conducted study within 151 participants, and study period was 1 month. In order to see the association, we use chi-square test. So this is the assessment of socio-demographic parameters. The mean age of the participants in the study was 48.54, and here we can see that most of the participants were females, that is 93%, and age group was above less than 60 years, that is 70% of the participants were elders, and education level, most of them were educated up to high school level, that is 30.5% were educated up to high school level, and socio-economic 20.5% were socio-economically in middle class, belong to middle class. Now coming to the knowledge parameters, these are the questions that I have asked to assess the knowledge. That organ was lungs, and only 82 were aware that then about 93% of the study about 93% of the study population believe that TB was preventable, and about 86% educational level. And this is the assessment of knowledge question, and we got that only 20 slide.
Continue, please.
Stigma towards the TB patients, and also regarding the
specific. And I wanted to know one thing was sample size. You said 10.6%. That is the prevalence you took. Prevalence of what? Prevalence you took. Prevalence of what?
Getting a biased study. They will be knowing more about the disease and transmission. Getting a biased study. They will be knowing more about the disease and transmission, and also in that adult who are working in healthcare sectors are being excluded.
Please stay back. Answered it very well. That you have to be very. Another thing is, you mentioned that your sampling technique is convenient sampling. How you collected your study participants, that you can mention, or that you can, that could be a sentence, need not be a word. Okay. And then your tool preparation, especially for a KAP study, how the knowledge tool is prepared, how it is validated. Is it going, okay, TB, what kind of an organism is causing TB? It's only 40% of relevant knowledge. You just look at their attitude. It is a Likert scale. It is going to increase, and 45% of them were having the highest level. That is 5 of things are there in your data.
Yes, Dr. Shweta. A very nice study, actually a very meaningful study, and your data is also, it has thrown up so many good things regarding the population which you have actually studied, you know. So that you just take care for your next presentation. Okay.
Thank you, ma'am.
Good afternoon. My topic of presentation is mortality among confirmed leptospirosis and dengue cases admitted in a tertiary care center in Thrissur district. So coming to the introduction, as we all know, the burden of both communicable disease and non-communicable disease are increasing day by day. So as per the WHO, nearly 33 million of clinically apparent dengue cases are happening in India each year, which contributing to the economically vulnerable people, mainly in the farmers, slum, in these areas. And in India, the Kerala is one of the main contributor for the cases of leptospirosis, and all districts of the Kerala is a contributor of leptospirosis. Coming to the mortality rates, when we consider, for an icteric leptospirosis, it varies between 10 to 15%, and in case of dengue fever, it's between 2 to 5%, but if there is no proper management happens, the mortality rate further increases. So the objective of the study was to compute the case fatality rate of the dengue and leptospirosis cases admitted in Government Medical College Hospital Thrissur from 2019 to 2023, and to illustrate the trend of dengue and leptospirosis cases from 2019 to 2023. Similarly, for the leptospirosis also, again this graph shows the number of probable cases and confirmed cases with the death is plotted on the. To the discussions and conclusion, the burden of both dengue fever and leptospirosis is increasing every year. So in a state like Kerala, we have a lot of factors like environmental factors which are favorable for both these communicable disease, dengue and leptospirosis. So improper waste management, rapid urbanization, improper town planning, all are the contributing factors for this increase. So since both are in a preventable disease, for the dengue, a health education regarding the source reduction, dry day, personal protective measures should be emphasized to the needy people. And for leptospirosis also, the health educations among the high-risk population like farmers who are working in slums or in the construction area, NREGM workers, all has to be emphasized. There should be a strengthening of chemoprophylaxis, and we should give the education even to the primary health doctors as well as the health workers regarding the importance of early initiation of chemoprophylaxis in case of leptospirosis is very important. And there should be a provision of personal protective equipment to the risk people. And we should have a good behavioral change communication to improve the health-seeking behavior for the public, since these deaths can be prevented by the appropriate measures in case of both dengue and leptospirosis. Thank you.
Dr. Masoma, good presentation, and you stuck to the time also. How did you calculate the case fatality rate?
It's calculated based on the total number of deaths happened out of the total number of confirmed cases for both dengue fever and leptospirosis, which are admitted in Government Medical College Thrissur.
Yes. So the total number of deaths could be deaths which are not confirmed also? Or
it's only confirmed cases of deaths.
Confirmed
case of death divided by confirmed cases of that particular disease.
Okay, so then why did you add an extra column for the probable cases?
Actually, I want to see the burden of the disease actually. Since in a setup like government college, we don't have that much facility for screening all the people. So it may be majority of them have not tested actually. Before that, sometime maybe person may be referring from some other center in a serious condition, or sometimes due to the limited resources we are not able to conduct the investigation for all. Hence, but it is sometimes clinically all the symptoms will be there, which is fitting for either dengue fever or a leptospirosis. Hence, we want to show the importance of that burden is there in the society. That's why I put the probable also. But for calculating the case fatality rate, I included only the confirmed cases and the confirmed deaths only.
So if you're including the probable cases also, will the case fatality rate be more or less?
I think it will be in the range because there are the cases, deaths happen in the probable also. So I calculated, but I didn't include that. But there is not much change in the case fatality rate since there are number of probable cases are there. Also, there is deaths with probable cases of dengue or lepto is there. So the number numerator and denominator changes sometime equally, so that the much change does not happen with the case fatality rate.
So what could be the reason behind the increase in number of cases in the past 2 years? 23, I think you got an
in the dengue fever, there is a previously in 2018 we had a large number of dengue outbreak happen, but I included that from the last 5 years. So after that in the literature we can find out every 4 to 5 years there is a large bulk of dengue outbreak happening, mainly because of the increased bulk of people with less immunity, because once the person is get dengue with one virus, that person will be immune to that. So by the 4-5 years, the number of unimmune persons will be increasing. That may be the one reason. Previously, we have in 2018 we have a large bulk, and in again after the 5 years, 2023 we had a high outbreak. One reason may be that.
Is that the situation with dengue? Are you sure that is what is happening in case of dengue fever?
Yes, madam.
Or is there a possibility?
Okay. It is actually you are seeing cases from the perspective of a medical college.
Yes, sir.
What are the errors that can creep in?
So since it is a tertiary care center, all the serious cases who does not handle in a primary or secondary level are getting
that. In some years in Kerala, the death rate in suspected cases were more than that in confirmed case. Because leptospirosis is so severe so that the system is not getting enough time to detect it. If your diagnostic system is improved and you are getting the data within 24 hours, you will get data for even severe cases. And that madam has got a point. When you are just using these kinds of data human transmission, diseases which has got human to human transmission has got a reduction in number during COVID. Because suppose you are there in your home, you are infected with dengue, you are not able to go out, and your family members may get dengue, but a place very distant from your house may not be affected by dengue that is infected by you. In 2019 and 20, that was the situation. All communicable disease spread has stopped. Because human to human, if human to human spread happen with or without mosquitoes, people has to move. So people were not moving. The hospitals, especially Thrissur Medical College, it was not very accessible to patients. Patients may be coming to a peripheral hospital which was very near to them. So the data of 2019 is not comparable with data of 2023 because of COVID. But when you are writing this paper, definitely these things should come. Okay, that is something. Otherwise, I think you have got a very limited data set and you analyzed it very well and presented it nicely. Thank you.
Thanks.
Dr. Masama.
Yes, sir.
Actually, my question was something related to what sir asked. Was COVID a factor?
Attacks are happening largely in between this gap of this 4 to 5 years.
So is there a possibility that 2016 and 17 rate was similar to 2018? Yes, sir said 2017. So that could be there, right? COVID would have played a factor in. Other than that, very good presentation.
Thanks.
Thank you.
that is jumping from an animal to a human source. So the early detection of such zoonotic disease is very necessary for a prompt response. And Government Medical College has been chosen as a sentinel surveillance unit for zoonotic disease. The other two colleges being Government Medical College Alappuzha and Government Medical College Trivandrum. So almost a year after its implementation, till last month, May 2024, under the National Health Program was used. So the study variables encompass symptomatic profile, the lab confirmation, as well as the risk factors. Then the spatial data was mapped using QGIS software to pinpoint case clustering and the distribution. If you're looking at the laboratory confirmation of the cases, we could only confirm 41%. And from that, leptospirosis was just 44%. The case of West Nile, Japanese encephalitis, toxoplasma, and Lyme's disease was confirmed by laboratory. So looking at the profile of the patients, the mean age of the patients were 48 years, and 73% of them were males. And among the patients who were admitted in our college, intermittent fever and also risk factor, 25% of patients had such a risk factor, and most of the cases, out of the 45, almost all the cases were either leptospirosis or the scrub typhus cases. History of domestic travel in the last 1 month, history of going to forest in the past 1 month, and history of contact has led to lab confirmation and early diagnosis of many diseases like brucellosis, West Nile, and Lyme disease. Additionally, Japanese encephalitis and dengue cases, though they were not prioritized, were
scientific, more theoretic.
It's a vector disease and it's a zoonotic disease.
Dengue is not a zoonotic disease. Dengue is not a zoonotic disease. Dengue was a zoonotic disease, but the zoonotic precursor is cut off. The sylvatic form of dengue is no longer there. As dengue is becoming an urban disease, dengue was a zoonotic disease because monkeys were involved in the initial formation of the virus. But now in the flavivirus group, dengue is the only virus which is not zoonotic. It's a classical teaching. Okay. When I ask this question, you just think and you need not defend. If you don't think that there is an animal involved in dengue, vector-borne diseases are not zoonotic disease. It is an entirely different group. So dengue is not a zoonotic disease. And it is not included in the this list also. When you are including purposefully, you have to be very double sure that it is a zoonotic disease. So that means dengue is not fitting to this particular list. That is one thing that I want to. Second one is, why Nipah is not there in this list? Because Nipah happened exactly during your study period. When Nipah as it is a very important zoonotic disease that is prevalent in Kerala, why you are not just...
So it was not present in data. Even I was confused. But in our data, when they started, it was soon after the Nipah. So it was not there in the data. It was from August.
Okay, definitely it's a very good study, very good initiative. This program is very good and it has got a very bright future, especially Calicut, Alleppey and Trivandrum has become as nodal centers or sentinel sites. It is very good. But I am just make you think. Another thing, you argued that urban clustering of zoonotic disease is because of the maybe wetland and all other things. So it is very difficult to have zoonotic disease, entire zoonotic disease is put in a basket. A single basket is not actually good. In this study, you have got really limited number. These are the things, but your presentation is very good, your level of confidence is good, and it is a very relevant topic and very important data. Thank you.
Yes, Linchina, my argument is also same as Dr. Anish, because all zoonotic disease may not have the same risk factors. So making a map showing clustering of all zoonotic diseases in one area may not be that practical. We really don't get an idea regarding what were the risk factors and okay. So individual zoonotic diseases, okay, you can make a map and say clustering is there in this area. No, that
now coming to introduction, according to latest World Malaria Report, there were 249 million cases of malaria in 2022 compared to 244 million cases in 2021. The estimated number of deaths stood at 608,000 in 2022. This is done from the malaria case registered during the period of 2020 to 24 are reviewed retrospectively. Data was education. Most of the cases were imported, that is 74%, and introduced constitute to 10%, and the remaining cases were recurrence, that is 5%, and relapse 9%, and indigenous cases 2%. Coming to the classification based on species, the Plasmodium vivax constitute 40% of the cases, and 43% of the cases, and Plasmodium falciparum 1.1%. And other signs we found was bleeding manifestations that constitute to 11.6%. Now coming to the conclusion, more than 2/3 of the cases are migrant workers from other endemic states. The major cause of the resurgence of the malaria in Kerala includes interstate and international travel, inadequate environmental sanitation, import of the cases, migration of the increased number of laborers from the other states, and urbanization. So active surveillance and treatment are needed to prevent the reemergence of the disease in Kerala. Thank you.
Yes, Dr. Sarangi, nice presentation.
The FIR reports were not, because we cannot see the symptoms.
Anyway, why we are saying is like it was talked about regarding the earlier presentation also. Movement of people are very less during this, because you said migrant workers are 63% migrant workers. During this time period, the number of migrant workers might have been very less. So you can't really say whether. But of course, migration.
Yes, malaria case is not there.
Nearly zero.
But nearly zero. But even in Thrissur, 2% is reported as indigenous. And you may be knowing that how these people are branding it as an indigenous case. Yes. If the person has got a travel history, maybe within 1 year from now, then that person may be labeled as an imported case. That means this is a grossly underreported. Indigenous case in Kerala is grossly underreported. Even then, you have got 2%. That means we have got indigenous malaria case. Currently, we have got large outbreaks is going on in Idukki district. And this is a very important thing that we have to think about. And you mentioned that one case of Plasmodium ovale was there.
Yes, ma'am.
How you diagnosed that this is Plasmodium ovale? Is it just morphology, or you went for some kind of a genetic analysis?
It was from the peripheral blood smear report release of Plasmodium ovale.
Usually, when you are getting a rare findings, you might have learned in the diagnostic test evaluation. If the pretest probability of something is very rare, then there is a chance of false positivity, high false positivity. Sometimes a Plasmodium falciparum can look like that of an ovale. So in these kinds of things, without genetic confirmation, it is very difficult for us to confirm that this is ovale or not, because it is a public health implication is very huge, because ovale is not seen in our part of the land. Okay, this presentation is nice. Thank you.
Dr. Sarangi, based on that slide, how do you tell there is an increase in trend?
Increase in falciparum.
You said increase in trend of only falciparum. Based on that slide.
This slide, there is increase in 2023. There is an increase in number of cases compared to.
How do you say there is an increase in trend?
Case load increases compared to the other years.
Make that statement, right? Increasing trend. Based on that slide, can you tell there is an increase in trend?
From that we cannot.
Okay. And you said imported cases, 74%. Can you define imported cases for me?
Define imported.
You said 74% were imported cases. Can you define imported cases?
Imported cases are that cases which get infected outside the area of which it is diagnosed. For in our perspective, it is a state. The case is getting infected outside the state, and it is diagnosed from our state.
You said 63% were migrant population. Was that the reason of that statement?
Other cases also were there. 63 among the imported. Most of the cases were migrant population, but in imported cases there were other cases also. The person with history of travel and.
What if they got infected here in Kerala? They're working here as workers and got infected here.
There was usually in the FIR report there was a history of travel, recent travel.
You did ask history of recent travel?
Yes, sir. Report it was based on the report.
Thank you. Good presentation.
Good afternoon all. I am Dr. Rehna. My topic for today is knowledge, attitude and practices regarding rabies prophylaxis among the adult population in a rural field practice area of a tertiary care center in Kozhikode district. Background. Rabies is a viral zoonotic disease with almost 100% case fatality rate. It affects the central nervous system of humans, which kills about 59,000 people every year globally. The majority of the deaths have occurred in Asia, that is 59.6%, and in Africa, 34.6%. In Asia, India accounts for 65% of total rabies deaths. In Kerala, 21 human rabies deaths have occurred in 2022, out of which only 6 received post-exposure prophylaxis. This study was to assess the knowledge, attitude, and practices regarding rabies prophylaxis. Objectives: to assess the knowledge, attitude, and practices regarding rabies prophylaxis among the adult population in a rural field practice area of a tertiary care center in Kozhikode district. To identify the factors associated with the level of knowledge regarding rabies prophylaxis among the study participants. Materials and methods. Study design was cross-sectional study. Study setting was in rural field practice area of a tertiary care center in Kozhikode district. Study period was 1 month, May 2024, after ethical clearance. Sample size was calculated 152 adults. P was equal to 26.29% from a study which was done in 2017 in Maharashtra. It was also a cross-sectional study titled Knowledge, Attitude and Practice Regarding Rabies Prophylaxis. And inclusion criteria included permanent adults, that were participants who stayed there for at least a month, period of 6 months, and who was willing to participate. And exclusion criteria who was too ill to respond to the questionnaire. Physically challenged, bedridden patients, as well as mentally ill patients. Data collection, house-to-house visit was done. And then study tool was semi-structured questionnaire, which included demographic profile, knowledge parameter, attitude parameter, as well as practice. And data analysis, scoring was done. Good score, above 50%, above 50% of the total score, we have given good score. And data statistical analysis was done by SPSS version 20. Results, socio-demographic details. Age group, 70.4% were less than 60 years of age, whereas gender, 67.8% constitute females. And educational status, most of the people were with primary education, that was 40.8, and undergraduates and postgraduates were 14.5 and 6.6 respectively. And socioeconomic status, 46.1% constitute upper class, and then 27.6 were upper middle class, and lower class were 6.6%. And results regarding the knowledge factor regarding rabies, that 78.3% knew that rabies was not 100% curable. Also, 81.6% knew that rabies causes death, and the causative organism of rabies was only known in 44.1%, and only half of the participants knew the correct measures to be taken after animal bite, and 74.3 participants knew rabies can be prevented by taking anti-rabies vaccine. And then only 17.8% of respondents knew it is safer in pregnancy, and the route of anti-rabies serum was only known in 10.5%. And then re-exposure, on re-exposure, a vaccine can be given, that was known by 63.2%, and 13.8% participants knew that recommended period like after revaccination was done, and then pre-exposure prophylaxis was known by 26.3% participants. And regarding attitude, regarding rabies, overall attitude of the participants was good. Nearly 80% of the people knew that rabies cannot be prevented by the application of indigenous substances, and 93% were known that it is necessary for preventing rabies. Vaccine is necessary for preventing rabies, and around 98% they supported for promotion of rabies knowledge in the community, and 77% were willing to take treatment. Only 77% of the respondents were willing to take treatment after a vaccinated pet animal bite, and then 98% were their willingness to recommended treatment for preventing rabies. And regarding practice, out of 152 participants, there was only 36 participants with history of animal bite. Out of 36 participants, around 36 participants, all the participants have visited the doctor after the animal bite, as well as took the rabies vaccine complete doses. But only 30 participants have took immediate medical advice after the animal bite. And the first aid done after the exposure was only 22% have done the correct first aid. That is, wash with soap and water for 15 minutes. 47 have done, they have washed with hands with soap and water, but not for 15 minutes. So 47% was wrong. And knowledge score was actually 29% was knew about rabies prophylaxis, and attitude and practice was good. And this is association, it was significant with association was significant with only education level. And conclusion, in spite being rabies a age-old disease, knowledge about rabies prophylaxis among the general population was found to be poor, that is 32%. 98 had a desirable attitude. Practice was good in 100% respondents, but first aid, which was given after animal bite, was very poor, that was only 22%. And health education sessions to be conducted at field level as well as school level.
Dr. Rahana, good presentation. I have few doubts. First one is, why did you choose adult population?
Sir, because they are the top, because they might be knowing more about rabies, and they are in the community.
Why do you want someone who knows more about rabies in your study?
No, sir, below 18, I have explored children or students.
Any specific reason?
No, sir, adult population.
Is the question validated?
No, sir.
And your attitude, can you just show me the slide again, please? Prevention of rabies by application of indigenous substances.
80% Their attitude was rabies cannot be prevented by application of indigenous substances.
Attitude or knowledge, it would be.
It have both knowledge and attitude.
Thank you.
Yeah, good presentation. I'm not repeating what I have already mentioned regarding the other KAP studies. Again, I want to reiterate one thing, that each and every questions do not have equal weightage. Because here you are measuring knowledge not to know that how much knowledge that participant has got, but you want to know how much knowledge is going to help the person provided he has got an animal bite. That is when you are approaching from the health point of view, that is very important. Whether this person know that soap and water should be applied soon after vaccination. Okay, these two things are very, very important. You may be having higher weightage compared to other things. If you go for some kind of a validation, just like Madam has mentioned, a content validation using some expert, then these things will be brought in, and your questionnaire will be maybe more suited for this one. Another thing is, you could know how much this knowledge is translated to. So the interrelationship between knowledge, attitude and practice. Is the same person who has got knowledge has got good attitude also. That is important. That is the premises where you are doing health education. You are thinking that while you are giving education, people's attitude will be changed so that people will practice. So is there any relationship between knowledge scores and attitude scores or something like that? That kind of an analytical questions could be asked. And third aspect, while you are preparing a KAP study, KAP is actually a very difficult kind of a study, even if it is very easy by looking like, but if you are doing a real KAP valid study, it is very difficult. Preparing attitude questions are very, 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 very difficult. So sometimes you may be asking something, but that may be knowledge. Okay, so attitude means, provided the person has got knowledge, the affective domain of that person. Okay, usually we will give some case studies, or sometimes we will assess in Likert scale whether you are agreeing to a comment, not agreeing to a comment. Rather than a dichotomous yes or no question, in attitude sometimes you can use Likert scales, and also that is a very tricky thing, that to differentiate the question from attitude and knowledge. So these things are important while you are doing a KAP study.
Yes, Rehna. Usually we assume that those who have an adequate knowledge, their practice level will also be high. The attitude and practice will be high. Here you have got, even though the knowledge level you are saying was only, what, 34%?
32%, ma'am.
But the practice is 100%.
Yes, ma'am.
How do you explain that?
Ma'am, because actually my five questions were there in practice questions. In that, apart from the measures taken just after animal bite, the rest of the 4 questions were, have you visited doctor? Then that was full 100%. Then they have did you take vaccine? Once they go to hospital, they take vaccine. The other question was, have you completed dose? It was taken. So, and after 5, almost 3 was correct. And the measures taken just after animal bite was very poor. So once they gone to doctor, rest all the practice questions were correct. Not correct.
So what you're saying is maybe your questions were not proper.
Not proper, ma'am, but now the questions were regarding practice
so
also.
That is either your practice question were not framed properly, or your knowledge questions were not framed. So there lies the importance of this validity, what you are saying. Okay.
Okay, thank you.
Good afternoon all. Myself Dr. Akhilji. My topic for today is verbal autopsy of TB death cases in a tertiary care center in North Kerala. Coming to introduction, Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. There are two types, pulmonary TB and extrapulmonary TB, of which pulmonary TB is the most common type. A total of 1.6 million people died from TB in 2021. And as per the National TB report of 2023, the number of TB cases in Kerala is at a rate of 67 per lakh people, and the national average is 176.2 per lakh people. So the rationale of the study was to assess the cause of disease and patient's pathway to death in order to prevent such circumstances in the future. So the objectives of the study to determine the events related to death in TB patients through verbal autopsy. So coming to methodology, so the study design was a verbal autopsy of 5 patients declared as TB death during 1st to 31st of July 2023 in a tertiary care center in North Kerala. The study setting was Government Medical College, Kannur. Study period was 10th October to 31st October 2023. Study population was a patient declared as TB death in July 23. And study tool was telephonic interview with the relatives of deceased patients using semi-structured questionnaire and from medical records. Coming to operational definition, there are 3 terms: patient delay, diagnostic delay, and treatment delay. Patient delay is defined as time interval between onset of symptoms, here it is TB, and the patient's first contact with the healthcare provider. Diagnostic delay is defined as time interval between first consultation with the healthcare provider and diagnosis. Treatment delay is defined as interval between diagnosis and initiation of ATP. So plan for analysis. Data was collected from case records, and details about the patient's cause of disease was collected from relatives through telephonic interviews using semi-structured questionnaire. So coming to results, there were five deaths in total. Out of that, all were males above 50 years of age. And coming to patient delay, 3 patients had patient delay, out of which 2 had significant patient delay, 2 patients had diagnostic delay, and no patient had treatment delay. Coming to comorbidities and other factors, 2 patients had previous history of TB, 4 patients had history of smoking, 3 patients had history of alcohol consumption, and coming to investigations, 3 patients had deranged LFT and 4 had deranged renal function test. The graphs are not visible. So coming to the types of TB, out of the 5 cases, 4 were pulmonary TB and 1 was extrapulmonary TB. And out of the comorbidities, out of 5 patients, 4 had comorbidities. 1 patient had diabetes mellitus, 1 patient had both diabetes mellitus and coronary artery disease, and 2 patients had COPD and hypertension, both each. The graph is not visible, sorry for that. And this summarizes the patient pathway. As you can see, 2 patients, that is patient B and D, had significant patient delay, and patients A and C had significant diagnostic delay. Conclusion. Among the 5 TB deaths, 4 were pulmonary TB and 1 was extrapulmonary TB. All the patients were males above 50 years of age. Comorbidities, that is diabetes, hypertension, COPD, smoking history, alcohol consumption, elderly age, male gender, and previous history of TB were the factors which were related to TB death. Among the 5 patients, 2 of them had significant patient delay and 2 had significant diagnostic delay. Hence, to summarize, delay from the side of the patient in accessing healthcare, and delay in the diagnosis by healthcare provider, along with comorbidities, were the factors which contributed to TB death. These are my references. Thank you.
Dr. Akhil, a very nice study. Actually, could you define what you meant by patient delay and diagnosis, or in other words, what is the ideal time of diagnosis, or what is the ideal time of patient coming in contact with a healthcare provider?
Ideal time, I'm not sure, but based on the symptoms and as such, if you suspect TB, it's better to do all the necessary investigations and do the diagnosis as fast as possible.
Yes.
So in this case, it was not there.
Yeah. Can you show me the definitions which you mentioned? That slide. Patient delay is defined as time interval between onset of symptoms suggestive of TB and patient's first contact with the healthcare provider. That is patient delay or time taken by the patient to access a healthcare system.
Yes.
Isn't it?
Yes, ma'am.
You can't call that delay. Suppose the patient accesses the healthcare system on the same day.
That is not
One
delay,
day.
ma'am. That is not delay. First contact, ma'am. First contact with the healthcare provider.
First contact with the healthcare provider.
So there will be no patient delay. If the patient comes to the healthcare provider, they
That
won't
is
be.
what I'm saying. So that definition is not of patient delay. That is time to access a healthcare provider, time to access a diagnosis, time to arrive at a diagnosis, isn't it? Delay, you'll have to have a separate definition for delay.
Okay.
Isn't it?
Yes.
Program does not have a
Definition.
Okay. Only 5 patients in 1 month.
Yes, only 5 patients.
Okay. Why you have not included, say, 2 or 3 months or 6 months or 1 year? I think that records will be readily available, isn't it?
Actually, ma'am, when I joined the college, I started the study. The study was conducted in my first month.
Oh, you are a first year PT.
First year PT. And in my first month, the study was conducted. So they just told to take 1 month.
1 month.
As data and analyze.
Maybe you can continue it and include a few more months, maybe 1 year data. Only then the findings
Yes,
will
ma'am.
have
Yes,
some
yes,
meaning.
yes, ma'am. Yes.
Yeah, Dr. Akhil.
Sure.
Nice attempt.
Thanks.
One thing is, I think the title of your study, you just mentioned it is verbal autopsy. So while hearing that, we may sometimes think, okay, how the verbal autopsy could be done. Okay, what are the verbal autopsy findings? So you can have a broader title, so that the title will communicate that you are going to present the verbal autopsy of these patients. So that is something I noticed. And second one is, you have got only 5 patients, you could say that patient 1, patient 2, patient 3, patient 4. So descriptive, rather than you can just go for this kind of a, because the 5, you cannot say that out of 5, 2, that is maybe 20% or 40% has got this. So the quantitative estimations has got a limitation. So you can say that, okay, this patient has got this problem. This patient has got coming to the medical treatment on this day, and it is maybe compared to taken more time for that. And this patient has got maybe another diabetes, and this is a this much year-old person. So when we will get a feel, okay, this kind of a person died because of tuberculosis. Even you can explain what was the symptom, maybe what was the mechanism of death and all other things. Maybe a case study, a small case study. That is first case, then second case, third case. Then it would have been more relevant.
Yes, sir.
If you have got 50 cases, definitely this kind of an analysis is maybe better. But while you have got a very small number, maybe a more descriptive analysis may be more fruitful. And another query I wanted to ask, the death rate in transgenders are maybe double that of males and females. Is it because of the concurrent HIV infection or something like that?
It's possible, sir.
Yeah. Thank you.
Dr. Akhil, sir. It's a very, very nice topic to start with, but was a little disappointed that the sample size was small. Maybe a little more, as both the judges said. Probably would have added more.
Yes, sir.
Probably add more. It's
Sure,
very
sir.
interesting. So, we need data on that. And one more thing was probably I wanted to know was on compliance of treatment probably. Maybe difficult to get from a family member still, whether they're taking treatment properly, all those aspects probably may add. That will give us important information. We want to know why the death happened,
Yes.
isn't it? Even though they started treatment, maybe that aspect also probably add to it.
Okay.
So interesting study to take forward.
Sure, sir.
Thank you.
Thank you.
Overall, I think I liked all the studies, but you know, it's becoming more right now, becoming even a data analysis, artificial intelligence can now, right? So lot of things were analysis of a data already there. So we need to add more to it in the future, time to come. These are all good studies. These all gave me lot of inputs that is needed, but probably add more. Just then taking data, we need to add more in it. Thank you.
Thank you. Again, very good studies, and it is very happy to note that so many young minds are coming and thinking a lot of things about the problem that we are facing now.
All the presentations were very good, and it's good that PGs even then in their first year are trying to, even if it's just analysis of already existing data, that is giving us so many inputs.
Good afternoon to all. Myself, Dr. Renju Raju, Junior Resident, Department of Community Medicine, Government Medical College, Calicut, presenting my study on topic clinico-epidemiological profile and trend of mumps cases admitted in a tertiary care setting in Kozhikode district, a cross-sectional study. As we know, mumps is a viral infection caused by paramyxovirus, and it is characterized by fever and parotid swelling,
Mumps can lead to complications such as orchitis, oophorytis, mastitis, meningitis, encephalitis, and pancreatitis. Recently, multiple outbreaks of mumps have been noted in Kerala, similar increase in Kozhikode also. Despite its preventable nature through vaccination, it's not included in the universal immunization schedule. In light of this, we have decided to conduct a study to study the clinico-epidemiological profile of mumps cases admitted to a tertiary care setting in the first quarter of 2024 and to analyze the trend of mumps cases admitted to a tertiary care setting from 2017 to 2024. In the methodology, we have done our study in a cross-sectional method, and study samples were all mumps cases admitted in Government Medical College, Kozhikode from 2017 to 2024 March, comprising 152 cases. And the socio-demographic and clinical profile of mumps cases were extracted from records of Regional Prevention of Epidemic and Infectious Disease Cell, and the rest of the data were obtained through telephonic interviews. The clinico-epidemiological profile of mumps cases from January 2024 to March 2024, consisting 74 mumps cases totally. Among that, 65% were males, as shown in figure 1, with a mean age of 6 plus or minus 3.4 years. 68% from Muslim religion, followed by Hindu and Christian. Coming to figure 2, it's a district-wise distribution of mumps cases from January to March 2024. 54% mumps cases were from Malabar district, followed by Kozhikode. And also 52.7% of mumps cases were within 5 to 10 years of age, followed by 22.9% in 1 to 5 years. We can see 18.9% of mumps cases were within 10 to 14 years of age. Coming to the figure 3, showing the distribution of complications in mumps cases, 44% of mumps cases were admitted with CNS manifestation like encephalitis, meningitis, meningoencephalitis, seizures, etc. and 40% with parotitis, 12% with other complications like pancreatitis, orchitis, oophorytis, otitis media, etc. 4% with no complications. 83% of mumps cases admitted was unvaccinated. 15 cases, that is 20% in the mumps cases, required ICU admission. Among that, 93% were unvaccinated with a median hospital stay of 3 days. One death has been reported, a 1-year-old unvaccinated male child. We also analyzed the trend of mumps cases between 2017 to 2024 up to March. It's comprising 152 cases. We can see the distribution of mumps cases from 2017 to 2024. In 2017 and 2019, there is a spike of mumps cases, and then there is a plateau. And 2024, we can see 74 mumps cases have admitted till March 2024. So, there has been a recent surge in mumps cases with complications mainly involving CNS manifestation. Public awareness and the isolation of patients are crucial to prevent the transmission. So, we can include mumps vaccination in the universal immunization program. The presence of mumps cases in early adolescence may necessitate a catch-up program also. These are my references. We extend our sincere gratitude to our HOD of Community Medicine and RPD Cell Coordinator. Thank you.
Yes, Dr. Ranju, very relevant topic considering the recent outbreaks of mumps in Kerala. How do you interpret this, figure which you have of complications of mumps?
Madam, total 74 patients were admitted in our setting, and 44% of patients were admitted with the CNS manifestation like meningitis, encephalitis, meningoencephalitis, and seizure disorders. And 40% mumps with a severe parotitis.
Yes. So, what is the important thing which you should stress over here? Because seeing that figure, it looks like all mumps cases are having so many complications.
Madam, I have done the study in a tertiary care setting. So mums with almost severe mums and with complicated cases are admitting in our setting. So there will be cases with asymptomatic or subclinical cases also. But in our setting, the patients will come with severe mumps manifestations. So among that, we got a 44% with CNS manifestation.
But even that is important because
Yes, sir. Yes, ma'am.
because
ICU admission can or more.
Because so much of complications can only arise if the total number of cases in the community is huge.
Yes.
More number of cases in the community means more
Yes.
number of
Complications.
Okay, what are your recommendations?
Sir, public awareness and isolation of the patient is very important, and also mums can be included in the universal immunization program. And also we can see in the early adolescent age group also there's a 18% of cases, complicated cases. So presence of catch-up, there is a need for a catch-up program, catch-up vaccination program also needed. That's my recommendation.
Okay. Did you done any further analysis? For example, here look like an age shift. 5 to 10 years contribute to 52.7%, 52.7%. Is it the vaccinated group or unvaccinated group? For example, I have got a hypothesis that the unvaccinated group will get mumps early. The vaccinated group will get mumps because they are losing their antibodies maybe later because of weaning of immunity. Then you can see whether the younger patients is unvaccinated and older patients are vaccinated. Or I have got another hypothesis that CNS complications may be more in maybe people having or children having mumps if they have got mumps in an later part. Something like that. You could have some analytical questions could also be addressed in these things. Did you attempt that kind of a
So I have a look on going to the complication part actually. I could see the complications are more in unvaccinated population. And also in Kerala there will up to 2017 there were MMR vaccine, then it replaced by MR. So the people with that age group had a lesser impact of complications as compared to other with unvaccinated status.
Again, adding on to that only, what was your result on vaccination and complications?
Sir, I could find out the complications were more in.
Like, do you have the data? What percentage do you have it? I understand that only there are these many you can put in a poster, but you would have analyzed, right? So what was the analysis?
Sir, about 88% of patients with complications were admitted with the history of unvaccination.
88%. And in comparative, okay, that's good. Fine. Based on this, what is your analysis on trend?
Analysis
on trend.
Sir, I could find out there is a spike of cases in 2017 and 19. Then there is a plateau. And in 2024, there is a rise of cases as we can see in the figure. That may be the reason why after 2017 there were no vaccination in our Kerala. So there is a susceptible population are born after 2017. So they are susceptible. But in 2019 we know there is a COVID outbreak was there. So after COVID outbreak, all people maintaining the social distancing and mask, and that may be one of the reason why of there is no cases in after 2020, 21, 22, 23, and 2023 May was the mask importance of mask is removed from our community. So that may be one of the reason people are not following this isolation or social distancing factor. That may be one reason.
One more thing, I'm just interested on it. Was there any association between the age and the complications? No, it is not there in this, so I'm asking. Did you analyze?
Sir, I could analyze one factor that I could find a mean age of 6 years from my study. Mum's cases with a mean age of 6 years was more in cases. And we can see after 2017,
No,
we
no,
are
no, no. I mean complication with complication age, without complication age. No. Thank you.
Thank you.
Your point regarding COVID and this lack of mask and all these things is actually good. And one more point is there, that suppose you are stopping vaccination now, you don't expect outbreak tomorrow, because there is something called a herd immunity. So the herd immunity will come down year by year. If you just stop vaccination next year, the very next year, again next year, then the herd immunity will be going down to a particular threshold, which is known as herd immunity threshold. Then only there will be an outbreak.
Yes, sir.
So that is why, even if you have stopped it in 2017, you are expecting outbreak only in 2022 or 23. That is another reason or explanation for that.
My topic is unusual presentation of a common pathogen. So about endemic fever, it's a communicable diseases mainly caused by Salmonella typhi. The route of spread is mainly through fecal-oral spread through contaminated food and water. It causes usually causes fever and also systemic infection, and also it affects multiple organs in our body as extraintestinal manifestation when it causes bacteremia. The main complications of the typhoid fever, other than the extraintestinal manifestations, are it causes pneumonia, meningitis, and also intestinal perforation, hemorrhage, encephalopathy, then also abscess in several organs. So nowadays the importance of the study is it's unusual presentation other than the common location of action, and also multi-drug resistance among Salmonella typhi. It's mainly shown in immunocompromised patients. So the objective of the study is to describe the unusual uncommon case of the pneumonia, causes of multi-drug resistance, and case of pneumonia as an unusual presentation of Salmonella typhi in an immunocompromised patient. So about the case history, an 80-year-old male who was admitted, he have multiple complex hospitalization history. He has comorbidities such as COPD, CAD, adrenal insufficiency, hypothyroidism, BPH, autoimmune CLD, etc. He was admitted with multiple episodes of loose stools. I have a fever, chills, then abdominal pain, and also with vomiting also there, cough and dysuria is there. So he developed this. He admitted to our hospital on March 20th, but disease was started in 17 itself. But after taking the home medications, the disease don't subside. Also, with aggravation of the disease, he came to our hospital. We were sent for stool sample, culture and sensitivity. Then also send sputum sample and blood sample for the sensitivity. Also, viral test was done. blood culture was done according to the BACTEC. There is automated blood culture methods. The result was first of all the Salmonella typhi was identified on the stool culture and sensitivity. Then surprisingly the next result was came sputum as positive for the Salmonella typhi. The importance is Salmonella typhi will not cause infection on the lungs. It is an uncommon presentation because then also blood also came for the positive for the Salmonella typhi. Viral was came non-reactive. Antibiotic sensitivity also tested by means of automated system Vitek2 biomerics, and the bacilli was positive for sensitive for the azithromycin, meropenem, and also cotrimoxazole, that is trimethoprim sulfamethoxazole. It was resistant to the commonly given drugs. Commonly, usually we will given ciprofloxacin, ceftriaxone, etc. for the Salmonella typhi, but in this case, patient is completely resistant to most of the drugs. There is ceftriaxone resistance, then ciprofloxacin resistant, ampicillin resistant. But he was sensitive. Even he is sensitive to ciprofloxacin. He is resistant to ciprofloxacin. He is sensitive to levofloxacin. Patient was treated with IV meropenem, and he responded well to the treatment. And after 10 days of treatment, he was discharged with levofloxacin oral tablet. So conclusion of the study, pneumonia is an unusual complication of the Salmonella typhi, and the prevalence of pneumonia in Asia is only 3% according to the study of Christine S. Marcello et al. And it is mostly because of the immunocompromised patient, status of the patient and multiple and complex hospitalization history of him. And also this case highlights the extraintestinal manifestation of Salmonella typhi, underscores the importance of considering such complication, particularly in immunocompromised patients, also because of the poor hygiene and also multiple hospitalization history. These are the tests done to identify.
Dr. Sriraj. A nice presentation. I actually was going through and I wanted to know what is the current incidence or prevalence of this particular case, because it's a rare case report, right?
Yes.
So previous cases, probably that I wanted in the introduction, that is what I was going for. So is there any data regarding it? Like how rare is this?
Only 3% according to the previous study is prevalence in Asia of Salmonella causing extra-intestinal. Usually it is intestinal manifestation only. Salmonella is intestinal and causes diarrhea and fever. But this patient is completely immunocompromised and also multiple hospitalization history. This spread through the blood, causes first bacteremia, then it migrates into lungs, causing pneumonia.
Probably that better to add in the introduction to get us a better idea of it, right? Okay. And can you just explain to me again the case history, which part of it was pneumonia? Cough with chills, which part was pneumonia there in the case history?
Patient came after 3 days. On the 17th March, patient started disease. We have patient admitted on 20th. That time only small cough is there. But it was identified pneumonia according to the clinical history, and they sent samples to our microbiology lab, and the stool sample was sensitive for Salmonella typhi. Sputum also came positive for the Salmonella typhi. That time only identified this pneumonia is caused by Salmonella typhi on that patient.
Thank you. In the case history, there was nowhere mentioned about pneumonia part.
Cough is there.
Am I missing?
Cough
only
is there.
Cough and
cough is there. Only cough is there. No other symptoms.
Like it was diagnosed based on X-ray, whatever. So that as
it is diagnosed only based on our culture and sensitivity report.
No, pneumonia.
Oh.
I'm not talking about Salmonella typhi. I'm talking about pneumonia. That aspect was missing if I didn't read, if I read it properly. So probably add that aspect also. Other than that, very interesting topic. Thank you.
Thanks.
It's very interesting. One thing is regarding your conclusion that it is maybe because of poor hygiene practices. that may be applicable for Western world, but in India, highly endemic for this infection, the person may not be, the hygiene may not be an issue at all. Even you and me, suppose we have got very low immunity, sometimes we may get exposed. That is what I think in a public health point of view. But if the background prevalence or just getting an exposure to Salmonella typhi is very rare in Western countries, sometimes. But here we can, in every hotels you may expose to maybe a Salmonella typhi, maybe because of the virtue of your immunity you are not getting the disease. But when we are looking at the Vidal, you can see that high titers. That means sometime in our life we are exposed to this bacteria. So that is why personally I think maybe hygiene may not be that much important in India. That is what I think. Just I'm communicating. And second part is this person do not have a humoral immunity response. The Vidal test is negative. So this is the sputum culture becoming negative is very, very important on a public health point of view. The person may be symptomatically better, but if he is still having Salmonella in his, not sputum, the stool sample, then it has got a public health concern. Like maybe typhoid Mary, you may be knowing the history.
Yes,
so did you conducted a serial analysis of stool culture, whether the stool culture become negative? So I am interested in that particular aspect, because sometimes the patient may be symptomatically better, but he may be excreting the bacilli through his stools, that the other people coming in contact with him or in the community may be in danger. Did you attempt that kind of things in this particular
before
case?
the discharge, few days before the discharge, stool sample was sent and came negative for the bacilli just for the discharge. And also patient is bedridden, can walk with the support, but when he is hospitalized, he is bedridden and diapers was using. And
it's a very very unusual case, and you've presented as a case report, isn't it?
Yes.
Now, when you present a case report, actually you have to have a very comprehensive case history, which will include his present complaints, past history, the investigations which were conducted. Like sir was saying, he could not find the X-ray findings over there, because you're saying it's a case of pneumonia, so you should have said the X-ray showed consolidation or something like that. So all his investigation findings, everything should be included. Maybe because you're from microbiology, you have included only the microbiological investigations, but usually when you are doing a case report, all the investigations which have, because he's got so many other comorbidities, and you're saying that comorbidities have played an important part in his manifestation as pneumonia, isn't it? So all those investigations reports should also be mentioned. See, hypothyroidism is there, autoimmune BPH is there, so many conditions he's suffering from. So he must have been intensively investigated also. So at least the positive findings you should have.
He was positive for total count, elevation was there. Before discharging, when he was improving, they sent the blood sample again and total count reduced. Patient then he's hemodynamically stable, and also
it's okay,
everything
just
get
I'm
negative.
saying, for future reference, whenever you're doing a case report, keep all these things
included.
Good afternoon, one and all. Myself, Dr. Sanuja Sharin, Postgraduate Junior Resident, Department of Community and Family Medicine, AIIMS Raipur. The title of my study is Trend of Mumps Outbreaks in India from 2014 to 2024, Analysis of IDSP Data. Mumps is an acute viral illness that presents classically with unilateral or bilateral inflammation of the parotid and other salivary glands. Although mortality for mumps is less, it may lead to complications such as oophouritis, orchitis, meningitis, encephalitis, and deafness. Vaccination with the mumps-containing vaccine is the most effective and established method to prevent this illness. Despite being a prevalent disease all over the country, mumps is considered as an insignificant public health problem, mainly because of poor documentation of clinical cases and lack of published studies. In fact, a very few attempts are being made to collect and review even the available data through various avenues. My objective was to analyze the trend of mumps outbreaks in India from 2014 to 2024. The material used was the weekly outbreak reports of IDSP for the period of 2014 to 2024. Using this, the number of mumps cases and outbreaks in India were collected and compiled to see the trend in the past 10 years. The results showed that there is a cyclical trend in the occurrence of mumps every 3 to 4 years, with noticeably higher number of cases in the years 2015 to 16, 2019, and 2023 to 24, with lower number of cases in the years 2021 and 22. As we look at the monthly trend of mumps outbreak, we could see that more number of outbreaks have been seen in the month of January and February, followed by a secondary peak in the month of August, with a lower number of cases and outbreaks observed in the summer months such as May and June. The regional distribution of mumps outbreaks in the last decade shows that states such as Jammu Kashmir, Punjab, Karnataka, and Kerala reported the maximum number of outbreaks, followed by the state of Madhya Pradesh and Tamil Nadu. If we look at the seasonal trend of mumps outbreak in these most frequently affected states, we could see that in the states of Kerala, Karnataka, and Punjab, the maximum number of outbreaks were found in the month of January and February, whereas a secondary peak in the month of August was predominantly seen in the state of Jammu and Kashmir. The analysis reveals a cyclical trend in mumps outbreaks occurring every 3 to 4 years with noticeable seasonal variations. The COVID-19 pandemic and associated lockdowns during the year of 2021 and 22 likely contributed to reduced transmission of this illness, mostly due to decreased population crowding, increased mask usage, and potential underreporting. The lower incidence in the summer months could be due to school vacations. Inclusion of a MMR vaccine in the national immunization schedule can reduce the incidence of mumps significantly and the associated morbidity and healthcare burden. These are my references. Thank you.
Dr. Sanuja,
yes,
very nice presentation. You've taken the IDSP data, I think, isn't it? In your chart, which is you have mentioned that the first figure which you have got,
yes,
the legend says the number of cases, the orange bars.
Yes.
And the red bars?
It's also number of cases only, but I have highlighted it since it shows maximum number of
higher
cases.
number of cases.
Yes.
So actually, if you are using a separate, ideally you should include it in your legend also. So your recommendations were?
Ma'am, I would recommend that as per this study, I found that in the month of January, February, and in the month of August, there is increased number of cases. So just before this month, we can increase the public awareness. So I would recommend that I would go for a, like my target population will be first of all school students, and then parents and teachers and general public. So for school students, we can distribute pamphlets and brochures regarding regarding about mumps, what is mumps, what are its symptoms, how will it transmit, and how can we prevent it. The same can be done to parents and teachers also, and also we can recommend them for MMR vaccine also, which is currently an optional vaccine. And for the general public also, we can do the same.
Sanuja.
Yes, sir.
thank you for bringing a pan-India perspective. One thing that can bias this particular information is the differential reporting of the states, because mumps is largely a mild form of infection. Most of the mum cases are not going to be reported. And a state which has got maybe a good reporting system or a surveillance system may report more cases, but some states. So these kinds of things will be there. So if you are going to plan a paper based on that, you can go for some survey data, maybe available in different states, and you can have some kind of that kind of adjustment. And you can say that, okay, this state which is highlighted to have high burden may not be really high burden, they may be reporting more number of cases. And to support or negate that, you can use the other findings that may be there in literature, something like that. That is one approach that you can do. Second thing is this particular pattern, that is the reduction number of cases in 2020-21 maybe because of COVID. And the higher number that is happening after that is maybe because of the phenomenon which is well known, just like immunity depth or something like that. The people or children, they might have infected in the previous year, are not infected, and they are infected this year along with those share that is there for this particular year. That may be the reason for that. That is there. And another thing that I have heard, especially the diseases like mumps, which is transmitted through air, it is transmitted maybe more through colder months. That is a universal pattern. It is very clear in influenza outbreaks of Europe and USA. So one thing is that there will be something, you can see that the northern states, Jammu Kashmir and maybe Himachal has got high mumps, maybe because of the airborne transmission happening in cooler months. The people's behavior can also contribute. For example, in cooler months, people will come together inside their homes, maybe in closed atmospheres, and all other things can happen. So these things you can bring in, and you can, because IDSP data, even if you are just like you are getting a pan-Indian perspective, there may be a risk of bias will be very high.
Yes, sir. Sir, in the state of Jammu, I could find that maximum cases were in the month of August. Rather, I was expecting it would be in the month of January or February, but it was found to be maximum in the month of August.
Dr. Sanuja, I liked your conclusion a lot.
Thank you.
Probably only one thing I would want here in the whole poster, maybe the operational definition, what the IDSP gives of what mumps is. Maybe that will give me a better understanding of what already is good. Right? Thank you.
Thank you.
Good evening all. I am Dr. Divya Priya from Madras Medical College. The study of my title is Prevalence of Respiratory Morbidity and Associated Factors Among Construction Site Workers in Namakkal, a cross-sectional study. Introduction. The construction sector is among the steadily expanding industries globally, and in India it stands as the largest economic contributor following agriculture. However, construction site workers are more susceptible to various health issues and illnesses, and only limited researches are conducted among them. Thus, this study is aimed to estimate the respiratory morbidity among construction site workers. Objective of the study is to estimate the prevalence of respiratory morbidity and its associated factors among construction site workers in Namakkal. It is a cross-sectional study.
done among randomly selected construction site workers of Namakkal district during September 23 to December 23, and the sample size was calculated to 310, and simple random sampling was done, and data was collected by interview method using a pre-tested semi-structured questionnaire, and spirometry was performed among the participants. Results shows that figure 1 showing prevalence of respiratory morbidity, 95.2% of the population had respiratory morbidity, of which 83.6% had restricted type of lung disease, and 11.6% of the population had obstructive type of lung disease. Figure 2 showing usage of masks, only 19.9% of the population reported to use mask during the working hours. Table showing association between respiratory morbidity and gender, and respiratory morbidity and years of working. Male gender were 3.6 times at a risk of developing respiratory morbidity compared to females, with a p-value of 0.04, and people who had worked for more than 5 years had increased risk of developing respiratory morbidity with the p-value of 0.03. Conclusion of the study, 95.2% of the people who participated in the study had respiratory morbidity, and associations were found between respiratory morbidity and male gender and years of working, which emphasizes the need for targeted interventions in occupational health management, prioritizing respiratory protection measures, behavior change communication, periodic health checkups among construction site workers, and limiting the working hours of workers with extended work periods are crucial to mitigate the impact of respiratory issues in the population. And these are my references. Thank you.
This is the fourth presentation, so I'm assuming I'm seeing the same pattern. So the slide pattern was given, is it?
Yes, sir.
Okay. It was a good presentation, visually also nice. I probably wanted the table to be a little bigger. Okay. I know, I understand the limitations of a poster. Maybe this thing a little smaller. I wanted to know one thing. It's occupational health related. I wanted to know the type of workers. Because that will give me an idea what type of workers were using masks, what type of workers were not using masks. So probably that would give me more data. And how you came up to 310, probably?
Based on the previous study done among same construction workers, sir.
Same?
Yes, sir. Prevalence of respiratory morbidity among construction workers done in Brazil. It was a study done there, sir.
And how did you assess this morbidity?
Sir, using spirometry, sir, with the values of FEV1 and FVC, sir.
Like you're taking more than 0.7, less than 0.7?
Yes, sir, 0.7.
But wouldn't that only give me obstructive lung disease?
Yes, sir, obstructive lung disease, restrictive type of lung disease, and mixed. Sir, obstructive type of lung disease where forced vital capacity is either normal or reduced, but FEV1 is reduced more than 80% of expected. Similarly,
continue, please.
In restrictive type of lung disease, FVC is that is forced vital capacity is reduced, but not the forced expiratory volume at the first second is not reduced.
So it has to be a high degree of morbidity.
Yes, sir.
Not mild pneumoconiosis and all a little bit. Sure. Thank you.
Thank you.
Yeah, Divya Priya.
Yes, sir.
Sir was asking the same question that I was planning. So one thing is it a real, what kind of meter this respiratory measurement you were doing? Is it a mini spirometer or is it a full-fledged?
Full-fledged proper spirometer.
That means the patients were invited to your hospital to do this?
No, sir. In Tamil Nadu, we have a labor mobile medical unit, sir, in each district. So they are equipped with spirometers, sir. So we did it in the field.
Nice. Then regarding that table, better you give the percentage also, because the numbers it is very difficult to comprehend.
Okay, sir.
If you give percentages, comparison will be easy.
Lot of effort taken to do the study. so that we recognize the effort taken. Otherwise, okay, nice presentation.
Thank you. Thank you.
Hello. Good evening all. My topic is on knowledge, attitude, practice regarding blood donation among general population in a rural free practice area of a tertiary care center, North Kerala. So coming to the background, as demand for blood is increasing day by day and current blood donation is insufficient to meet the demand, and it is critical to measure the knowledge regarding the blood donation, also the attitude. And so in order to remove any roadblocks, we need to improve the blood donation rates and ensure a safe and sufficient blood supply. So my objectives are, one is to assess the knowledge, attitude and practice regarding blood donation among a general population in a rural field practice area. And second is to identify the associated factors related to knowledge, attitude and practice. Coming to materials and methods, I've done a cross-sectional study out of 145 participants, and age inclusion criteria is from 18 to 60 years. And I've done a convenience sampling, and I collected the data using a self-administered semi-structured questionnaire consisting of 51 questions, including the questions were on socio-demographic variables, knowledge, attitude and practice. And the scoring was done. That is, the participants having a score more than 50% of maximum possible score was characterized as having good knowledge, attitude and practice respectively. Coming to the results, looking at the pie chart, we can understand the knowledge of the participants, that is, it is not seen. 75% had good knowledge, and the mean age of the participants were 37.9 plus or minus standard deviation 11.6, and 62.1% were females, the rest all were males, and 35.2% were unemployed and 40.7% belonged to the upper class. 53.9% females and 50 of the males had good knowledge, and 62% of the participants less than 40, and 39 of the participants more than the 40 years of age had good knowledge. And knowledge was significantly associated with age, employment status and socioeconomic status. And attitude was significantly associated with education, employment status and socioeconomic status. And the finding I got in that is 68.4% of all those who had never donated blood were willing to donate in future. Coming to the association tables, knowledge was significantly associated with attitude. That is 88.2% who are having good attitude had good knowledge, but 60.9% had good attitude in spite of poor knowledge. So that difference in 20 adds on to the significance. And attitude is significantly associated with practice. That is 36.7 had good practice and good attitude, but 19.4% had good practice in spite of poor attitude. Similarly, knowledge was significantly associated with practice. From my study, I would like to conclude that there is a general lack of awareness regarding blood donation, and the prevalence of blood donation among the participants were low, especially among the females. And however, majority of them had a good attitude, and so I would suggest there should be an education program to be conducted on blood donation so that we can increase the blood donation rates. That's all. Thank you.
A very relevant study, I think there is some inauguration of blood donors forum being done in your college today, isn't it? What did you define as good knowledge over here?
The score more than 50%.
50%.
Yeah.
Like you were saying for the previous studies and all,
Yes,
was there
ma'am.
any validation of your study?
No, madam. Validation was not done for the questionnaire. Was not validated.
Yeah, nice study. As madam has mentioned, the real problem is the validation of questionnaire. When you are saying that, okay, they have got good knowledge, whether actually they have good knowledge or not, we can only say after the validation of the questionnaire. That is the only concern we have on the KAP kind of studies. And another thing, you have brought out some kind of an analytical framework also. And you are saying that, okay, creating knowledge is useful because it is very well translated to practice and attitude. Good, thank you.
Dr. Ashwin, most of the things have been told. Only thing is I didn't get the pie chart.
Yeah, so
There is no
it was there
value.
actually.
It went off.
Yeah.
Can you just tell me again?
Yeah, the attitude is more. That is 75% had good knowledge regarding blood donation, and 75% had good attitude towards blood donation, and only 52 has got good knowledge regarding blood donation. The percentage has got.
Good afternoon. I'm presenting my study on the topic exploring the knowledge, attitude and practice of acute respiratory infections among mothers of under 5 children in a tertiary care center in Thrissur district. Acute respiratory infection is one of the major causes of mortality and morbidity among children under 5 years of age. Every year they account for the deaths of around 4.3 million children worldwide. As we know, there are many risk factors for acute respiratory infection, including the socioeconomic status, environmental conditions, housing conditions, indoor air pollution, among which the knowledge, attitude and practice of the caregivers accounts for one of the most important factor which can influence the mortality and morbidity associated with acute respiratory infection. The objectives of my study were to assess the knowledge levels of acute respiratory infections among mothers of under 5 children in a tertiary care center, to explore the attitudes of mothers towards ARIs, including the perceptions of severity and susceptibility within the healthcare setting, to determine the practices adopted by mothers in the prevention and management of acute respiratory infections in under 5 children within the tertiary care center, and to identify the factors which were associated with the knowledge, attitude and practices regarding acute respiratory infections among mothers of children under 5 in a tertiary care setting. It was a descriptive study which was conducted at Amala Institute of Medical Sciences, Thrissur, and the sample size was calculated to be 86 with P which was taken as 65.6, that is the proportion of mothers who had good practices regarding acute respiratory infection, and was taken from a previous study. The study was conducted from January to May 2024, and it included mothers of children under 5 who attended the pediatric OPD. Data was analyzed using SPSS version 23. Categorical variables were presented as proportion and frequency, and continuous variables were presented as a mean. The study was conducted using a validated semi-structured questionnaire. Coming to the result, the study included 90 mothers of children under 5 years of age, and with a mean age of 31.36 plus or minus 3.75 years. Majority of them were postgraduates, and 46.7% mothers were healthcare workers. Approximately 2/3 of the participants resided in rural areas and belonged to 3-generation families. Additionally, 41.1% had their youngest child between the age group of 1 to 3 years. 60% mothers had excellent knowledge, attitude and practices regarding ARI, followed by 32.2% mothers who had moderate levels of knowledge, attitude and practice regarding ARI, followed by 7.8 mothers who had good levels of KAP regarding ARI respectively. Figure 1 shows the level of knowledge, attitude and practice of acute respiratory infection among mothers of children under 5. As we can see, in most of the cases, majority of the mothers had good or excellent knowledge, attitude and practice regarding ARI. Table 1 shows the association between the level of knowledge and the socio-demographic details. We can see that mothers who belong to APL families had better levels of knowledge as compared to those who belong to BPL families. And also mothers who were healthcare professionals had better levels of knowledge as compared to the others. And mothers who had higher education, that is postgraduate level or higher, had better levels of knowledge as compared to the others. Table 2 shows the association between attitude and practice with the socioeconomic status of mothers. As in both cases, mothers who belong to APL families had better attitude and practices regarding acute respiratory infection as compared to the others. There was also significant relation between knowledge with attitude and practices of mothers. Statistically significant association was found between age and practices regarding ARI of mothers of children under 5. However, no association was found with other variables such as religion, residency, etc. My study concludes by saying that almost all mothers possess a good understanding of acute respiratory infection, including their symptoms, the risk factors, the danger signs, and their approach to ARI was effective, which led to appropriate practices. The study also shows various factors which influence the maternal knowledge, attitude, and practice, and these factors could enhance the quality of care for children with ARI, thereby reducing the related mortality and morbidity. And these are my references. Thank you.
Dr. Susan, can you tell me, according to you, what are the bias in your study?
This was mainly conducted in a healthcare setting, in a tertiary care setting. So most of the mothers who came there had higher levels of education and belonged to an upper class of the society. So if I would like to conduct the study again or based on another study, I would conduct as a field-based study.
Other than that? And your third objective, to determine the practice adopted by mothers in prevention and management of ARI. Where are these?
Sir, I've summarized it. Actually, I used a questionnaire, and the questionnaire had 3 sections, section B, C, and D. And B was regarding the knowledge, which included 16 questions. So it was more of like, do you know about the symptoms? Do you know about the danger signs? And the second section was the attitude. That is, do you agree, or how much do you agree? And the third one was, how often do you do this? Like, do you practice such things such as immunization? Do you take your child for immunization properly? It's not mentioned here. Like, I've concluded all of them together. I haven't mentioned them separately.
Thank you.
Thank you, sir.
Yeah. Dr. Susan, it's nice study. One good thing is you mentioned your objective very clearly. Okay, this is how I think you have to state your objective.
Thank you, sir.
And as he has mentioned, if you are not able to give the data if you are giving the data, you have to discuss that. That is while you are writing an article on that. And another thing is, in the tables, there is some mistakes. One is, you just look at the first table. First table is testing 3 hypotheses. One is the relationship between socioeconomic status with knowledge. Second one is occupation with knowledge. And third one is education with knowledge. So you should get 3 p-values. You might have getting 3 p-values and all the p may be less than 0.05. That may be the reason that you are putting only 1 p-value there.
Yes,
but that is not a proper way of doing it. Okay, you have to similarly in the other you have to put 2 p-values because 2 hypotheses are there. Because people will think that this is a single table.
Okay.
But it's not actually a single table. So in that also you can give the total number. So that table is not giving you an impression how many total APL people were there. So you can give an N there, an APL, N is equal to, you can add all the people in the row and put there. So otherwise we have to add, the person who is reading has to add these things. So you can make the tables more communicative, that is what I think.
Yes, Dr. Susan. A very good presentation. It's good to see that you validated your questionnaire. How did you validate your
It
questionnaire?
was already validated from the study from which I had taken. It was created based on the guidelines from WHO, and they validated that questionnaire.
So it was a
using-
standard questionnaire
Yes,
which you
yes,
used.
ma'am.
That's good. Yeah. That reference could have been.
I put the reference one, the first one.
Yes, exactly. That's nice. Okay, apart from that, no, nothing. The table also I noticed the single p value.
Okay.
So next time maybe you can improve.
Thank you.
Good evening. My name is Dr. Fahima, first year junior resident, Department of Community Medicine, Government TD Medical College, Alappuzha. My poster presentation is knowledge regarding airborne infection control practice among medical students. Airborne disease is caused by microorganism which is transmitted through the air. It can be transmitted while coughing, sneezing, or talking, or any activities that generate aerosol particles. It has an important NTEP program. Our medical students are coming with contact with these patients with close proximity during their clinical posting. Hence, the purpose of my study is to assess the knowledge regarding them. Objective of my study was to assess the knowledge regarding airborne infection control practice among medical students. Going into my materials and methods, I used a cross-sectional study design was conducted during the period of May 2024 among the medical students of Government TD Medical College, Alappuzha. My sample size was 364 and I took a semi-structured questionnaire which was administered through Google form. Data was analyzed with SPSS version 27. Qualitative variables were expressed in percentage and quantitative variables were expressed in mean and standard deviation. And also I assessed the knowledge score by taking 10 key knowledge questions, and the correct answer was given 1 mark and the wrong answer was given 0 marks. Going into my results of the study, the mean age of the study participants were 21.16 plus or minus 1.64 years, and the majority of the participants, about 65.1% were females. Going into my result in proper, I assessed the knowledge regarding the transmission, the favoring factors and the preventive factors. Majority or about 91.5% were aware about the common mode of the transmission, and half of the study participants were aware about the size of the droplet nuclei and the size that easily drawn into the lung alveoli. Only 23.1% were known that airborne and droplet infection is different, and 97.5% responded that overcrowding is a facilitator for airborne infection transmission, and 97.1% responded that hand washing with soap and water or alcohol based sanitation can prevent the transmission. Only 28.8% were correctly responded to recommended social distancing, and among the going into the knowledge score, I compared the knowledge score between the gender and with also with the batches. Female gender got higher knowledge score around 7.62 plus or minus 1.08 standard deviation, and the knowledge score about the second years were higher. Going into the conclusion of my study, majority of my participants has a good knowledge regarding the airborne infection control practices, but knowledge regarding social distancing and the droplet nuclei size were comparatively lesser. Hence, I need to emphasize the airborne infection knowledge regarding airborne infection control practice as a control measures to decrease the airborne infection. My references are given. Thank you very much.
Fahima. A very
Yes, ma'am.
relevant study.
Thank you,
It's good that you did it among the medical students. And I see a sample size of 364, which means you have given it to all the batches?
Yes, ma'am.
Or-
Actually, 170 students are there in every year. I calculated the sample size using my previous reference study by applying 4 PQ by D square formula. That prevalence was around 56.6%, ma'am. So I got the sample size as 314.
But you have given the Google form to everybody.
Everybody, ma'am.
Put it in their groups.
Yes.
And this was taken during class hours, or they can respond to it whenever they want.
Yes, whenever they want. I give a time period. When the response was 364, I stopped the Google form.
Okay.
It was about the
What was the
sample
time frame you gave for them?
For 7 days.
7 days.
Yes, ma'am. Because that was holiday period due to that heat stroke.
Given this 7-day time period, could that influence the findings of your study?
Majority of the students were there in home, and final years was responded quite less, and majority of the participants were first year and the second year. So when I calculated about the knowledge score, that is why the second year become more knowledge score than other batches.
So year-wise, there might be some difference in knowledge. Maybe if you had analyzed it that way, it would be more.
Number of participants were already more among first and second years, and the mean age was 21.
Coming back to the previous question, how could that 7-day frame affect your results? They are medical students, isn't it?
Yes.
Do they have ready reference for all these questions? So that could be one, but in spite of that, they are not getting enough scores.
Yeah, ma'am. About the social distancing also, only 28.8% correct. Correct answer.
Dr. Fahima,
Yes.
nice study. I don't have much to add other than the usual concerns that we have already raised and what Madam has already mentioned.
Dr. Fahima,
Yes, sir.
what exactly was asked when you said droplet, airborne infection and droplet infection are different? What was the question?
The question was, is airborne infection or droplet infection same?
It
or
was a
not?
yes or no
Yes
question.
or no question, sir.
The probability
Yes
of
or no and don't know, and don't know was combined with no.
so the probability of guessing and getting it right is also there. If I
Only
don't know an
25?
answer, I can tell yes or no based on guessing also, right? So that probability would I come
Don't
into?
know was also there in option, sir.
Fine, fine. So there would I go. Other than that, I think ma'am asked everything.
Yes.
Thank you.
Thank you.
So good evening. I'm Dr. Aishwarya KP, currently a PG resident, first year PG resident from the Department of Community Medicine at MAS Medical College, Perindalmanna. So the topic that I've chosen is the effect of diabetes mellitus in the tuberculosis treatment outcome among the TB patients of Malabar district. So as you all know, tuberculosis continues to be a deadliest disease in terms of morbidity and mortality rates. According to WHO 2022 estimates, about 7.5 million people were affected with TB, out of which 2.75 million people were reported from India. Diabetes similarly is also shown to have a high prevalence recently, that is about 10.1 people were affected recently during the year 2022. So this co-epidemic with diabetes escalates the burden of TB through early reactivation of latent TB, increased treatment failure, emergence of multi-drug resistance TB, as well as treatment failure. So my objectives were to find the proportion of diabetes mellitus among the TB patients of Malappuram district and to compare the treatment outcome between the TB patients with diabetes and without diabetes. So methodology I have done a cross-sectional study using data of about 2,323 patients registered at the Malappuram District TB Center in the Nikshay portal. So the socio-demographic factors were analyzed and the TB treatment outcome were compared along with multi-resistance between the TB patients having diabetes as well as those without diabetes. So coming to the results, so first I've shown the socio-demographic details, that is among those aged less than 40 years, the proportion of males and females are almost similar, whereas the proportion of males is higher compared to females in the age group 40 and above. And the odds ratio, that is the risk of TB death, is about 1.76 times higher among the TB patients with diabetes compared to patients without diabetes. Next, the proportion of diabetes among the TB patients, about 2,323 patients, culture positive TB patients, the proportion of diabetes was about 32%, which is shown in the dark area in the pie chart. Next, in order to increase the, in order to show an accurate death rates, I have expressed the death rates by calculating the in 1,000% years. That is about, it is about 0.54% 1,000% years for diabetes as well as 0.48 in non-diabetes. So to conclude, diabetes is a risk factor for TB death. So an active treatment, an active diabetic screening as well as routine monitoring is required for for better treatment outcomes as well as to enhance the diabetic complications throughout the treatment. Thank you. So these are the references.
Dr. Aishwarya, good presentation, very well displayed slides. One doubt, whenever the objective is, your objective is diabetes and treatment outcome, I know you have added like hypertension, other comorbidities and all, but it doesn't come under the objective as such. Right? Result should be representative of the objective. Probably associated factors, but as a risk factor, I know it's giving me additional information, need not be.
Yes, sir.
Right?
That is, sir, first of all, I had found out the association between diabetes as well as the risk of death in TB. And in order to remove the confounding effect, I had collectively removed the comorbidities other than diabetes to find if there is any risk. I've also done a regression which I couldn't add to the presentation.
Probably adding that would give me more value than the other aspect. And all the patients were taken into consideration. What was the sample based on?
Sorry, sir?
The sample size was based on
about
all the
2,323 patients, culture positive TB patients who were registered in the Nikshay portal.
Everyone yes, were taken into consideration.
Sir, I had removed those who were lost to follow up throughout the treatment. Apart from that,
they were removed. Right. And I'm a little not sure about the figure 2. Which is diabetes and which is not the?
So the darker area is the proportion of diabetes, that is 32%.
32% were diabetic among all the cases.
Dr. Aishwarya.
Yes, sir.
Very relevant topic, maybe one of the most relevant topics that we are now discussing. I have some concerns. One is, your title is Effect of Diabetes mellitus on the Treatment Outcome.
Yes, sir.
Usually, in a cross-sectional study, it is very difficult to study the cause and effect relationship. If it is a case control, it is some analysis is that of a case control, but basically it is a cross-sectional design. So you can just mention that diabetes mellitus and treatment outcome in tuberculosis, so that the people who is reading your paper can judge is it the cause and effect relationship is there or not. So that may be, if I am putting this as a title, I won't put effect of diabetes mellitus on treatment outcome, because I am not very sure that this is whether the effect of diabetes or not. That is one point. Second one is treatment outcome. I can see death in TB and drug resistance. Did you analyze the treatment outcome or the cure rate?
Yes, sir. I had, for analysis part, I had broadly classified the treatment into those who had died throughout the treatment and those who were cured with completed treatment. In order to focus and emphasize more on the death among the TB patients, because all our SDG goals and MDG and even NTB focuses on reducing the TB death. Moreover, the
treatment outcome, actually, why you are treating tuberculosis? It is for cure of tuberculosis, not to avoid death from tuberculosis. If that is the case, even you have to change your title as such. That is what I think. So if you are going to study the outcome of tuberculosis, you have to very clearly, you have to say what is the treatment success in diabetic group, what is the treatment success in non-diabetic group, is there any significant difference or something like that. Maybe one of the key results that you have to mention. That is what I think. And another thing is, regarding, you mentioned that you did a regression. That is good. I was about to ask that. Because you can see that more than, if I just take your table number 1, that is death, above 40% has got 4.68 times odds of dying compared to an younger person. Okay, the odds of a person aged more than 40 years to become a diabetes is also very high. That means age appears to be a very strong confounder.
Yes,
okay, people may be dying because of their age more than 40 or more than 50 or more than 60. And we can put that on the account of diabetes. It is not actually diabetes, but it is age. So creating a model, because it is an observational study, the only thing that you can do is a regression. Creating a model where you give age also as a variable. On the age, after adjusting age also, do you think diabetes is a risk factor preventing them from a cure or leading to death? What is your result? It's very important. It's a major result. So the regression, sometimes you may not be able to give a table, but you have to give what is your key result. After adjusting age, what happened to diabetes? Is it still a risk factor or it is gone? What was your result?
it is still a risk factor.
It was still a risk factor. Okay, thank you.
Very good study, Dr. Aishwarya. My concerns were the same as Dr. Anish. One was the confounding of diabetes with, and the other one was the outcome which you mentioned. You have just mentioned the death as the outcome. The other cure you have not mentioned. Otherwise, it's okay.
thank you everyone for making this session so fruitful. I thank our esteemed judges for the time that they have spent with us, for the knowledge that they have shared and the experience that they have shared. So it was our privilege to have you all with us, and also I thank all the postgraduates for wonderful participation. So we hope that this session will prove to be useful for your future research. So whatever feedback you have got from the resource persons, you should use it for your further research. Thank you all once again. So we see you tomorrow.